interstitium is something in between. So
last minute, please.
Yeah, and that's how the interstitial changes look. When you're looking for interstitial changes, or in a normal X-ray, you should be seeing only the lung markings, the vessel markings. Okay, if you see anything additional than the vessel markings, then that's all interstitial thickening. You look for anything additional which you can't explain as a vessel, then that's all interstitial thickening. Okay, so these kind of tiny nodules you see, they are all actually interstitial nodules. The pneumonia, we'll discuss pneumonia in the next session. And this just want to show one case which is looking like a mass. It's actually a pneumonia, but it's a non-smoker presented with a partially treated pneumonia. So that's how it came, and it resolved with the treatment. Okay. Yeah. So this is the last X-ray, or last 2 X-rays, and you got this patient with the fever, cough, and you got interstitial thickening there. You can see additional lines. And the key thing in this X-ray, you got the answer what you're looking for. Pneumonia is there, but then you look at the ribs and the bones, you can see they're like sclerotic. Okay, you can sclerotic spine, sclerotic ribs, there are prostate secondaries. Okay, so that's the, and you can, looking into the bones, you have to look at the corners, you can miss fractures, you can see dislocations like AC joint dislocation here. And this is the last X-ray. The patient came with sepsis and all telltale signs of right lung pneumonia. And as you can see here, you straight away look for right side, you see a consolidation there on the side of the heart, and you know it, and you found it. And then you can see there's a lot of haziness on the right side, but you know that it is rotated to the left. So that explains that. And as you look down, you can see there's a big lytic lesion there, which turned out to be a myeloma. So even if this X-ray gives a straightforward answer within a first second that you can see a pneumonia, still you need to look at the rest of the areas. A key diagnosis will be lying there. Okay. So
thanks so much.
Yeah.
Could you like to complete that slide?
Yeah. So okay, the key thing: never substitute a chest X-ray for a chest examination. Always mention whether you're a smoker or non-smoker. Have a pretest probability. Develop personal review areas. Always discuss with the radiologist for a lateral chest X-ray if needed. Aware of normal variants. Compare with old films. That's the best friend you can get. Yeah, we'll come back.
Fantastic. Yeah. Thank you very much indeed, Dr. Afsar. I feel like sitting and listening to you just like that for another couple of hours. And I'm acutely aware that there are about more than 100 people in the waiting room who are unable to join us. Unfortunately, even though we have got the full subscription for 500 people. So we would like to get that sorted.
Sorry, Dr. Maksud.
Yeah, Dr. Yes.
Can I intervene? We actually got the YouTube sorted now.
Okay.
It's live. So we don't have to have that break. So we just got it now.
So we continue.
So, Mr. Rubas, can you share that YouTube link on here as well on the chat window? We have shared it on all the groups, YouTube link. So we just got it sorted. So we don't want to interrupt the program.
Yeah, it's been shared now.
Yeah, okay, Dr. Maksud, you can continue. Thanks for that.
That helps tremendously. Thanks ever so much. Otherwise, I was a bit skeptical, about how people will be able to rejoin. But thank you. That's very kind of you. Dr. Harris, now over to you. Now that we do know what the chest X-ray looks like, what to look for where, but what are the clinical implications? How do we interpret, how do we correlate these chest X-rays with the clinical presentations? You being the chest expert and just having been on the COVID ward as well, I'm sure you'll be able to tell us a lot more and in a very interesting way. Over to you, Dr. Harris. Yes,
Thank you, Dr. Punecker.
Yeah, I can hear you as well.
Thank you. It gives me immense pleasure to join this session. And what I would like to do is over the next 25-30 minutes, I'd like to share my experience and my skills around interpreting chest X-ray and why chest X-ray is important in the initial assessment and management of any acutely unwell patient. Without any further ado, I'll just get started with this first case, which is a 65-year-old smoker who came in with acute shortness of breath, cough with possible hemoptysis, but it was not clear in the history, central chest pain, nausea and vomiting with no significant past medical history, perfectly fit and well. lady who came in with these acute symptoms. Obviously, she was tachypneic on admission. She was tachycardic. Breath sounds reduced in the left lower zone with dullness on percussion. Obviously, the three key tests that I would like to do, or that I would want anyone who is looking after an acutely unwell adult patient, would be a chest X-ray, a blood gas, and ECG. These are the three very important skills one may need to have when we are reviewing or when we are looking after any acute or any acutely unwell medical patient. Let's first start with the chest X-ray. This is obviously a plain chest radiograph. And if I can just point out some of the abnormalities.
Sorry, Dr. Harris, do you intend to share the images? I can't see the images at the moment. So maybe if you could.
How about now, Dr. Punegar?
No, I can't see them as yet.
How about now?
No. Yeah, now it's appearing. Yes, excellent. You've got it. Brilliant.
Okay.
Please proceed.
Perfect. Let's start with this chest X-ray. Like Dr. Afsar has clearly given a lot of insight into interpreting a chest X-ray and the importance of looking at the key findings. On this chest X-ray, probably we could look at the most important finding or the most important area of abnormality, which is around the left mid to lower zone. And there are a lot of artifacts, which is the wiring. If we can take those out of the equation, probably we could just talk about a dense homogeneous opacity in the left lower zone. And the possible underlying causes could be many for this presentation. And based on the clinical presentation and based on the chest X-ray and ECG findings, we thought it was obviously a type 1 respiratory failure because the patient was hypoxic with no CO2 retention, probable underlying pneumonia with in view of raised inflammatory markers, and the chest X-ray that we are seeing, underlying pleural effusion, which could be parapneumonic. It's a spectrum when we talk about pleural infection, starting from a simple parapneumonic effusion to complicated, and the far end of the spectrum is emphysema, which is pus. And the patient also was in AF with acute renal failure and metabolic acidosis. But one question remained: the patient was symptomatic with worsening, persistent chest pain, and that basically raised a list of probable other causes, including acute MI, because we know that multiple pathologies can coexist. And there was also a possibility that is it a PE? And this patient went on to have a CT scan, and we were looking at every possible cause. And the patient, in the meanwhile, we went back and we had a look at the chest X-ray. And if we closely look at the chest X-ray, if we look at the lower border of this rib, this appears to be more prominent compared to the other side. And there is paucity of lung markings in the left apex. That basically suggests that it's possible that this patient may be having a hydropneumothorax. But now the question is, how did the air get into the pleural cavity? And this is just a zoomed in view of the hydropneumothorax with the left apex. And the patient had a CT chest. CT chest did show air within the left hemithorax with pleural effusion. And this patient went on to have a chest drain, and bloody effusion was drained. And basically it was towards the end of evening, it was a weekend, and I still didn't have a clue, or I still didn't have a reason why the patient had hydropneumothorax, or how did the air get into the pleural cavity with no previous history of pleural intervention. The possible causes would include external trauma, or it could also include a previous intervention, which the patient didn't have. On further review of the CT scan, it looked like there was air around the descending aorta. This is a CT view. This is the mediastinal window. We are looking at the right lung, the left lung with the air here, and this is the collapsed lung and with effusion, and there's air around the descending aorta. And we had a chat, obviously, with the radiologist who suggested a barium swallow. The patient went on to have a barium swallow, and clearly you can see the chest drain there with the contrast leaking within the left hemithorax. And this turned out to be a leak through the esophagus. and the patient was immediately referred to the cardiothoracic center in Liverpool. And within 24 hours, the patient went on to have an esophageal repair. This, we would call it a golden hour in patients with Boerhaave syndrome. And we went back and we reviewed the diagnosis. It was basically a pneumothorax secondary to Boerhaave syndrome. This chest X-ray throws in quite a lot of key learning points. And one of the most important learning points from this is the importance of doing a chest X-ray and its role in basically the initial assessment and management. It just basically adds to your list of probability. It will give more confidence in terms of your list of differential. And like Dr. Afsar was saying, this is one of the imaging where real-time interpretation is key, because the decisions are made at the front door, the decisions are made at the coal face. And when the patient is there, you're basically looking at the chest X-ray and making real-time decisions. And structured approach to review all key areas is key. And sometimes we feel obliged to come up with a diagnosis when we are asked to look at a chest X-ray. My advice would be to start describing the features, make a list of differentials, go through the background risk factors, symptoms, and clinical examination. And this also tells us the importance of prompting further confirmatory tests. And we sometimes have to look at the primary unifying cause for this complex clinical presentation. There are a lot of anatomical areas that we need to cover on a chest X-ray when we're talking about respiratory diseases. In addition to respiratory muscles and the rib cage, we're talking about airway, lung parenchyma, and the lining of the lung. There are some diseases which will affect only the airways, some which will affect the lung parenchyma, some which affect the lining of the lung, and there are also some which will affect all the three. And in addition to the respiratory diseases, we are also looking at the mediastinum. We are looking at the hilar changes, like Dr. Afsar just mentioned. We are looking at the large vessels, the musculoskeletal and the soft tissue, the esophagus, which goes down behind, and the diaphragm, and the upper abdomen is also key. Many a times we have seen patients going into a surgical assessment unit with a lower chest pain, and thinking that it could be something to do with the liver, or it could be cholangitis, or it could be coming from the subdiaphragmatic area, whereas it was just a right basal pneumonia. And this basically highlights the importance of doing a chest X-ray in anyone presenting with symptoms starting from below the neck, below the mandible going up to the belly button. I would certainly want to have a look at the chest X-ray. It's important to look at the normal variants, like Dr. Afsar was saying, the azygous lobe and dextrocardia. It's important to rule out artifacts, the wiring, the tubes, and the lines. Now, chest X-ray interpretation, like a good old friend, it's always important to go back to start with probably the oldest chest X-ray to see what the normal is, because there is nothing called normal in clinical medicine. And it's important to go back and try to compare and contrast. This will give us a lot of clue. If there are some changes which are chronic, which are persistent, they're less likely to be infective, they're less likely to be acute inflammatory, or less likely to be malignant. Whereas changes which acutely evolve or within a few days are more likely to be infective or mechanical or inflammation. And on the other hand, when things start to slowly increase or change over time, probably over weeks or months, we ought to think about malignancy as a possible underlying cause for the changes. We always need to describe the features. Probably we could start off with describing it as probably a mass lesion, or airway, airspace abnormalities, or airspace shadowing, or an opacity, either a well-defined or ill-defined, or a subtle opacity, either bilateral or unilateral, or a homogeneous opacity or a heterogeneous opacity. These are the things where these are the terms that we could use to describe the features, and then come up with a list of differentials, what it could be. And we also obviously need to look at the zones, because we are not commenting on lobes on the chest X-ray. And it's important to look at the apices, the bases, especially the retrocardiac area, and basically have a second look at the key areas to make sure that we are not missing anything. Because obviously there is a talk later on about the medical legal obligation on somebody who's requested us a test and to interpret the images and to act on it. Let's start off with a theme here. Basically, I have got 3 chest X-rays in front of me here, and almost all the 3 chest X-rays, I would call it a whiteout or complete whiteout of the lung with no significant, on one of the X-ray, there is a mediastinal shift, but it's mainly a whiteout, a unilateral whiteout of the lung, which means the pathology is on the same side. Now, let's have a look at the limitation of the chest X-ray. It's very important to understand how much information this imaging or the plain chest radiograph can give us. And if in doubt, we could obviously go for plain a CT chest, or we could go for a repeat chest X-ray. On this chest X-ray, if I were to look at and interpret on a busy acute take, I would say that this looks reasonably unremarkable, apart from very subtle changes along the right heart border. And there is no obvious effusion. I can see the costophrenic angle appears clear, and there is no blunting of the costophrenic angle. But the same patient, when the patient was sent for a CT scan, we can see at least a moderate amount of effusion. We need to realize that obviously we're not comparing like for like. The patient is lying down in a supine position on a CT scan, and we can see the effusion, which is a free-flowing fluid just sitting in the base here. And just going back to our first chest X-ray, which we saw earlier, this is a complete whiteout. And what could it be? What are the underlying features, or what are the underlying causes that could give rise to this appearance? It could be either collapse, consolidation, underlying mass. It could be one of the many things. On this chest X-ray, it's almost impossible for me to tell where the diaphragm starts or where it ends, where the costophrenic angle is, because it just is a homogeneous opacity. The reason why we see different structures on chest X-ray is because of different densities. Because if two different densities sitting next to each other, if they basically have two different densities, it shows up as a demarcated area. Otherwise, everything will look the same. And on this, the next example probably we can pick up is another whiteout with no shift in the mediastinum. The contralateral or the left side looks unremarkable. Patient went on to have a CT scan. There appears to be a mass lesion invading the mediastinum. This is a CT scan. This is the mediastinal window, mainly looking at the soft tissue. We can see the mass, and we can also see some a small amount of pleural effusion. And this patient went on to have ultrasound. Ideally, we could have done a bedside ultrasound straight away without even having to go for a CT scan, because if it had shown pleural effusion, this could have been drained. But anyway, the patient went on to have a pleural tap, and we can clearly see that the fluid is clear, but whereas the dense mass remains. It simply suggests, or this case highlights the underlying multiple pathologies that can exist behind the chest X-ray. And this is another example of a whiteout where there is shift of the mediastinum to the other side. This we can call it a large mediastinal mass, possibly with large pleural effusion. And on the CT scan, we can see a large mass there with narrowing of the left main bronchus. And this is a non-contrast CT scan, and we can also see some effusion. There is a bit of aerated lung that is reflecting here on the plain chest X-ray. And this turned out to be a large B-cell lymphoma. The patient went on to have treatment. We drained the fluid. We can see the chest drain there on this chest X-ray. The patient went on to have the clever treatments that the hematologist would offer, and we can see that the tumor has completely melted. This patient was referred to me for a possible stent, but the patient was fortunate enough to have a very good response to the treatment. And now this is the post-treatment chest X-ray, wherein there is hardly any effusion, the drain is still there, and the mass has reduced in size. This is another example of a whiteout. We can see a dense opacity going up to the mid-zone, then it starts to blur. There is no well-defined margin. And this patient went on to have a chest ultrasound. The chest ultrasound shows a hyperechoic area here. This is the diaphragm, this is the liver. Chest ultrasound is one of those imaging techniques, easy to learn, quick to adapt. It's all about looking at the descriptions and looking at the patterns, and looking at the patient then went on to have a CT scan, which showed a heterogeneous mass, a large mass lesion invading the mediastinum. And this was in fact just the right hemithorax completely filled with a large mass with no obvious effusion. This is just to compare what a clear anechoic pleural effusion looks like. It just looks black, like the black shadow on a chest X-ray, which reflects air. Likewise, a black shadow on the ultrasound reflects clear fluid. Let's have a look at this 91-year-old with, again, a mass lesion. This appears to be a mass sitting in the right mid-zone. This appears to be more pleural-based, that we could say, and this extends along the right lateral border. The patient then went on to have a CT scan. CT scan indeed confirmed that there was an area of abnormality on the right lung. And changing the contrast, this basically was the fat density. We can look at the fat density here, the muscle density, and the bone density. Okay, and if we compare the fat density to the fat density here, this looks more like a fatty lipoma sitting within the right hemithorax. This is another example of a lesion sitting here in the right mid to lower zone. And the patient had a CT chest. Obviously, here you can see the difference between the previous one and the current one. The density here is more of fluid-based density. The patient went on to have a chest drain, and most of the fluid was drained. You can clearly see this was more of a loculated effusion. And when we're talking about pleural effusions, I would always be worried about two things, either infection or cancer. The rest of the effusions, I'm less worried because most of the other effusions are symptomatic treatment depending on the amount of fluid or depending on the symptoms. The first two things we ought to rule out is it infection based on the clinical history or is it cancer? There is another subtle area of abnormality here. What could this be? This again looks like probably a pleural base because just going along the lateral wall of the right hemithorax, the patient then had a CT scan. The CT scan showed a lesion sitting there, then went on to have a chest ultrasound. The chest ultrasound basically showed a loculated pocket of fluid with thickening of the wall there, and this indeed turned out to be a loculated infected pleural effusion. This could be a sequel of previous pneumonia, or it could just be a benign looking fluid sitting there. This is another example of an area of abnormality in the left lower zone. This is reflected on the CT scan. There is a bit of pleural enhancement. I don't want to go into the details of the CT scan here, but this is just to demonstrate that this is a fluid density, and this is confirmed again on the ultrasound. The reason for basically looking at ultrasound and other modalities is mainly to highlight the role of chest imaging in understanding the chest pathology. We have got chest ultrasound, CT scans, MRIs, and PET scans to our advantage, and depending on what the likely diagnosis or what your degree of suspicion is, you may want to choose one of these. Or now, moving on to the next theme here, we've got nodules, opacities, lesions, masses. These are just the descriptive terms that we are using when we are trying to tell or convey the message based on what we are seeing on the chest X-ray. Either it could be solitary, multiple, well-defined, ill-defined. You can basically go on to describe it in the best possible way that you can. And this is just an example where we are seeing a raised right hemidiaphragm. We are seeing a dense lesion here. This is sitting basically out, this going beyond the cardiac border. Obviously, this is not a part of the cardiac shadow here. This could be either inside the lung, or this could be either an artifact. This is another example of a well-defined dense area within the airway. Always when you're looking at the chest X-ray, start off with the trachea, because the large airway is more important to us than the small airways. Even if the small airways are normal, whereas if the large airways are blocked or basically compromised for whatever reason, then the patient is in trouble and we are in trouble. And clearly we can see something blocking off the left main bronchus. This was obviously noted on the bronchoscopic view. It's important to basically send this patient for a bronch to have a look at the airways from inside. And this is right main on the right, left main on the left, and that's the coin sitting there. This is the posterior wall of the trachea, and we can see the anterior tracheal rings. And this is another example of a coin in the right main bronchus. One of the first early indication of bronchoscopy was foreign body removal from the airway. And this is another example of, again, a very normal looking chest X-ray. This was done as a baseline prior to starting DMARDs in a patient with rheumatoid arthritis. There was, if you look closely, there is a very subtle area of abnormality here. The patient then went on to have a CT scan. The CT scan shows a lesion sitting right next to the dome of the diaphragm. And this patient then went on to have a PET scan. And this indeed turned out to be a malignant lesion. This is another example of very subtle area here, perihilar. These are the areas that we need to closely look at, suprahilar or perihilar areas. And there is obviously the tortuous aorta sitting here, but we are more interested in this lesion. And this is what the CT scan showed. This is another example of a very subtle area here. If we don't look for it, it's important that we look at these key areas closely and to rule out that there is nothing obvious or there is no abnormality there, because some of these findings could be incidental, and this could be a very important finding. And if it turns out to be early cancer, we are talking about early curative cancer. And sadly, if we miss or if things get missed, then it's like a missed opportunity. There is a very subtle nodule there. The patient then went on to have a CT scan. What next after CT scan? How can we say that this nodule is malignant or benign or whatever? The next best test that we have is we can do a PET scan. The PET scan indeed showed a mildly avid lesion here, and depending on the background history of risk factors, the patient could go on to either a wait and watch approach or a surgical resection. This is another example of a subtle area of abnormality here. This is the infrahilar area of abnormality on the left side. This is another example of a very subtle area of abnormality across the left suprahilar area. And closely looking at this chest X-ray, we can see some abnormal lesion here sitting along the right heart border within the lung. And this turned out to be, again, a cancerous lesion or a malignant lesion. And it's important to realize that these are the blind spots that we have on the chest X-ray. Anything sitting behind or in front of the cardiac, things are easy to get missed or less likely to be noticed. This is another example of a subtle lesion there that, again, you can call it a nodule. Anything less than 3 centimeters, you can call it a nodule. And depending on the depending on the risk or depending on the probability, the patient can go on to have further investigations. This is, we can see 2 bilateral lesions, symmetrical lesions on both sides. This is like somebody having a bilateral cellulitis. It is rare, but it is possible. And this turned out to be synchronous tumors on both lungs. This is another example of ill-defined area in the right mid-zone. Probably this was dismissed as just an area of atelectasis or probably post-inflammatory changes, but over time this increased in size and this turned out to be a cancerous lesion. Nodules come in different shapes and forms. One is a solid nodule, part solid, ground glass, and multiple nodules. And there are multiple causes for a nodule. One is malignant, infective, or inflammatory. The malignant, it could be primary or metastatic or other lymphomas, carcinoids, and sarcomas. And when we're talking about infection, it could be mycobacterial infection or fungal. We are talking about probably other possible cause of inflammatory conditions giving rise to lung nodules. Usually there will be multiple, and based on the risk, we can use something called a Brock score. If the patient has a PET scan, we can use something called a Herder's score. We can do bronchoscopy. That may not always get hold or get us close to the nodule, but at least it will give us an idea. Image-guided biopsy will be key probably in these cases, and sometimes we may need to go in for surgical resection, which would give both the diagnosis and which could also offer the therapeutic option. Sometimes we choose wait and watch, depending again on the risk. Cavitations and fluid on the lung. This is again a baseline chest X-ray done again in a rheumatology clinic. We can see an area of subtle abnormality in the left apex, and that turned out to be a cavitating lesion on a CT scan. And 3 months on follow-up, this lesion had completely resolved. Between these 2 scans, the patient had a bronchoscopy. It showed Staph aureus on the washing. The patient was also started on cyclophosphamide, and in the meanwhile, the patient had both antibiotics to give the patient the benefit of doubt if it was a staphylococcal infection, and also given the history of Wegener's granulomatosis or granulomatosis polyangiitis, the patient was treated and that basically almost resolved, leaving behind a thin scar. Cavitating lung lesions. What is the differential for cavitating lung lesions? Again, infection, inflammation, cancer. We're talking about infection, bacterial infections, aspergillus, TB, non-infective, which could be related to inflammatory conditions. It could be malignant conditions giving rise to cavitating lung lesions. There is no way on imaging we can differentiate or we can comfortably say if it is either of these. Sometimes previous imaging would be helpful. This is another example of subtle area of abnormality here in the right upper zone with some air spaces there. And this, in fact, turned out to be a cavity with a thick-walled lesion, a thick-walled cavity in the right upper lobe, and that turned out to be a malignant lesion. I put basically 4 slides here. On the left is the same patient taken at different levels. This is the arch of the aorta, and this is the left upper lobe, and we can see a thick wall lesion there. On the right, we can see thin wall lesion. There is no way of me telling which of these is either a malignant or an inflammatory condition, because lesions look more or less the same. 38-year-old lady with multiple nodular changes on the chest X-ray, went on to have a CT scan. CT scan showed multiple cavitary nodules. Some were solid. The patient then went on to have a biopsy of these. Usually, if it is multiple nodules, we are talking about either metastatic or on a background history of connective tissue disorders like rheumatoid or granulomatosis polyangiitis. It could be one of those. And this is just the example of very severe cavitating lung lesions. And this is over time between 2008 to 2015. We can see these changes have evolved with time. And at one point, the patient had a massive hemoptysis. And this over time, some of the scars or some of these nodules have resulted in scarring of the lung. This is another example of a large cavitary nodules on both lungs. And this is what it would look like on a CT scan. If we come across this, how would you investigate this? The first thing is to rule out infection. Either you can get a sputum sample or straight away go for bronchial washings, treat the patient for what is obvious, what is common infection, and then go on to treat. Or once the patient has been ruled, or once the infection has been ruled out, the patient can go on to have immunosuppressive medications depending on the underlying cause. This is an example of a hydropneumothorax. We can see both the air, we can see the fluid level, air within the right hemithorax. This is just to highlight that sometimes a hiatus hernia could also be wrongly diagnosed as a hydropneumothorax. Say, for example, if this line were to go all the way across to the left lateral wall, this could be easily mistaken as a hydropneumothorax. And this is another example of paucity of lung markings here. And we can see an area of abnormality here at the hilar with a fluid level. This, in fact, turned out to be infected cavitating bulla or infected bulla in somebody with severe emphysema.
Sorry to interrupt. You have another 5 minutes, Harris?
Okay, 24-year-old gentleman with, again, complete pneumothorax. We can see paucity of lung markings with a fluid level. If I were to see this for the first time, this could just be a reactive pleural effusion with a bit of fluid level in the left base. And the patient had a chest drain. And 2 days, on day 2, this fluid started to increase in size. Anything basically that rapidly changes, we need to start thinking, is it infected or is it something else? This turned out to be bleeding within the within the left hemithorax. And the patient went on to have VATS that didn't show any bleeding point, but this is just a potential complication of pleural interventions. When we are talking about obstructive airway diseases, we have got endoluminal problems, extraluminal, and mixed. This is just the example of a tumor sitting within the airways. We can basically look at various strategies to deal with endobronchial obstruction. We can look at using stents, and we could also look at basically burning the tumor. And this is a good example where the tumor was completely burnt using organ plasma coagulation with good effect. This is how I would use organ plasma. This is the trachea, this is the anterior wall, and we're using the organ plasma to burn and to completely debulk the tumor from the trachea. This is just an example of endobronchial tumors completely blocking off the airway, resulting in post-obstructive pneumonitis or post-obstructive pneumonia. Probably I'll just move on to the last couple of slides. This is just an example of a suprahilar lesion here, and another example of a lesion sitting here, which is a right paratracheal area of abnormality, and another area of abnormality here along the left hilar. And this was a massive thyroid goiter, almost completely pressing the trachea, forming a narrow slit. And this is quite evident on the CT scan that the large goiter with a heterogeneous opacity or heterogeneous changes is pressing on the trachea. If I could go straight for this is basically one case that I just want to discuss towards the end. Here we can see what looks like probably a pneumonic consolidation with possible underlying effusion. And another example of a homogeneous opacity here with subtle changes in the right mid-zone. And this turned out to be an area of consolidation with endobronchial tumor and endobronchial tumor causing post-obstructive pneumonia with air bronchograms. This is a good example of what a endobronchial obstruction can result in. And this is basically dense consolidation going down to the right lower lobe. And this turned out to be an endobronchial carcinoid completely blocking off the airway. And this is just an example of complete shift of the mediastinum towards the ipsilateral side. We can see the central line also moving along with the trachea with the calcified aortic knuckle. We can see the aortic knuckle there, and basically there is complete collapse of the left lung. What could it be? It could be one of the many things. I think we just need to go look out for the old, good old friend, the most recent chest X-ray. We can see the central line there, and this was day 2 of admission to critical care when the patient had completely collapsed the left lung. And this was most likely because of mucus plugging. We did the bronch, cleared the secretions from the airways, and this was straight after clearing the mucus plugging within the left airway or left main bronchi. If I...
We lost your...
Yes, lost. We lost your slide.
It appears to have happened there. Dr. Harris, you were mentioning that if the flow is good, allow me for another couple of minutes. I was going to do that. Would you like to take those 2 minutes?
Okay, are you able to see this one?
Not as yet. I mean,
Okay.
usually you are fantastic, but this talk so far has been incredible. Brilliant. Try and see if you can get those 2 slides. Yes, it's appearing.
It's appearing here.
Yeah, can see that.
Okay.
Yeah.
If I could share.
207 slides. That is an amazing amount of hard work that you've put in. Thanks ever so much. I think we must have another session.
Thank you. This was basically 18-year-old, known asthmatic, came in the middle of the night with worsening shortness of breath. On this chest X-ray, what we can see, just to basically keep it quick, we can see a line going down across the right hemithorax, and we can see another parallel line going there. And this patient turned up to ED in the middle of the night with increasing breathlessness, and this was interpreted as a primary pneumothorax. The patient went on to have a needle aspiration. This was post-aspiration. Chest X-ray showed some changes across the other side. It's possible one can have bilateral pneumothorax at the same time, but 2 hours later, the patient started to become more breathless. You can clearly see paucity of lung markings here. The lung had gone down on the right side, and this turned out to be a non-rebreathable mass sitting in front of the chest, which the patient was given at the time when the patient came into resus, and this was wrongly interpreted as a pneumothorax on the right, resulting in true pneumothorax after a simple needle aspiration. This just goes on to show that it's important to rule out any artifacts. Think twice before you put a needle in. Ask for help or ask the radiologist to see if they can basically help you interpret the findings, or sometimes you may just go on to do a plain CT chest to look for any other features, because there are a lot of this is a good example with paucity of lung markings. This is an example of a large bulla sitting in the left upper zone, and hardly any lung there in the left upper lobe, and this can wrongly be interpreted as a pneumothorax. This is another example of hardly any lung with some streaks there. This again, large severe bullous disease, and unlike the complete pneumothorax here with obviously paucity of lung markings and the lung has gone down here. This is just an example of paraseptal severe emphysema. This is almost a lungless disease. This is not a pneumothorax, but this is just a severe emphysema. We can hardly see a few streaks there. This is a good example of how a severe emphysema can present as, and how it can be wrongly interpreted as a pneumothorax. Thank you. Just the last few slides, or last slide, I would say, which is my key learning slide. It's important to interpret chest X-ray in the clinical context. It's important to go back and look at the risk factors. When we're sitting down with the medical students, I always say, yes, we can go on to have a look at the past medical history, but I would put all of those under risk factors, because we are all at risk of having something at some point of time in life. But the risk goes up if there are obvious risk factors like smoking, say, for example, or occupational exposure. Multiple pathologies can coexist. It's important to think, not just stop on one pathology or one abnormality that you're looking at the chest X-ray. Complete your detailed review. A structured review is very important. Even if you're asked to review a chest X-ray in the middle of the night, medical legally, we are obliged to do a complete structured review and basically document the findings and act on it. Look out for incidental findings. Always think there are limitations of a chest X-ray. The chest X-ray does not give all the answers to the questions that you're asking, and always think about other imaging modalities. Thank you very much for your time.
That's fantastic. Thanks ever so much. Feel like clapping for that talk. That was simply wonderful. I was actually thinking that maybe we'll be feeling a little bit sleepy, and then I would hand over to Dr. Siddiq Pulakal, who is the regional sleep expert and a senior respiratory consultant, so that he can take the question and answer sessions and keep us awake. But we are already awake, Dr. Siddiq. So over to you for the next question and answer session. Dr. Siddiq Pulakal, as I mentioned, is a regional sleep expert for the Manchester region and the Northwest. He's my guru in many things as well. He's done his MD, MRCP, FRCP, and postgraduate certificate in medical education, as you can see. Works in the South Manchester University Hospital, and also the chairman of the Upahar, which is a registered charity which promotes stem cell and organ donor registration among Asians in the UK, and I've registered myself with that as well. Over to you, Dr. Siddiq.
Thank you, Maksud, for your kind words. Now, because of the time, we will just go into question and answer session. I cannot see many questions on the chat room, but probably because it looks like the presentation were quite fantastic and they covered everything. So, but if I could just ask maybe one or two questions to Dr. Afsar. Are you there, Dr. Afsar?
Yes, I'm here.
Now, you mentioned that the chest X-ray reading has to be personalized. So, would you mind sharing your personalized way of that secret, and we'll decide whether we should follow that or not?
Yeah, right. Okay. So I'll do one thing. I'll straight away pick one X-ray which is there open in front of me. Right. Okay. So this is like whenever I look at X-ray straight away, first I stare at X-ray for few seconds. So usually we see them straight away. You can see the findings, and if you can't see the findings, then you start from one end usually. So I always start from the below the diaphragm. Okay, below the diaphragm, you see anything, these claustrophrenic angles, then go behind the heart and come up to the hilum and go up here and go to the lung apices. Then I go through the rest of the lung fields, then go outside. That's how usually I go. So initially I just stare blindly, and most of the time we may get the findings, then go by what is the indication. Yeah, that's how I go. Yeah. So because that's the thing. So sometimes some people always start with the apex. Some people always look behind the heart, the review areas, because of the past experience, missing something or seen somewhere. So that's the key thing. Yeah. So you have to personalize that, because if someone says, okay, make a habit of looking like this, it doesn't happen actually. It's not easy to change your habits. So create a habit where you pick everything in your own way. Yeah.
Again, do you have any, obviously some of the lesions most people miss is on the ribs. Do you have any kind of a way of,
I think,
your own personal way of looking at the ribs?
I think we will come across one case next session.
All right, okay.
Yeah, I think we already seen two cases on sclerotic metastasis and lytic lesion on the ribs. Yeah, we'll discuss that in the next session. Yeah.
Okay, excellent, very good. Now, one more question, if I ask you. Now, when as a physician, when we ask for a lateral chest X-ray, the radiologists get a bit kind of irritated, because obviously they think most of things can be seen at the PA view. But for clinician, we are always unsure about, because patient may have a kind of history which we don't feel fully comfortable. So could you just list or kind of situation where
Yeah, I
the lateral view, which is useful.
Yeah, I can understand, but it depends on what is the question you are putting forward. Okay. If the question you're putting forward is that if you're suspecting a lung malignancy, then there's no point in spending time on lateral X-ray and those things. Okay, so that's the key thing. So you need to do the next investigation. You need to do as more definitive, more conclusive. Okay, and that's the reason why most of the time we said there's no point in wasting time on lateral X-ray. Go for CT. Or if the radiologist can confidently tell you that, okay, what you're looking for is not there on the PA, you won't see it on the lateral X-ray, different cases. Where it can be really useful, I've told you already that the ectatic aorta, that's something where you can really useful. Where you can, you don't suspect anything. In an elderly, you see that, and there's nothing symptomatic there in the chest regarding that, but still you just want to confirm it. You can do a lateral X-ray, that will help. Middle lobe pathologies, again, you are suspecting something in the middle lobe, and clinically something is there's a chance of cancer, then it's better to go for CT. Even lateral X-ray will show the same thing. If they show or not show, still the cancer is not ruled out there. So those are the main reasons why this thing. But many times nowadays, I think people may not know, like outside that UK, the majority of the X-rays are reported by the radiographers. Okay, quite majority. And so the radiographers nowadays, they see, once they do the X-ray, they see the image. And if a lateral is indicated, most of the time they add a lateral straight away. That's happening in my department most of the time. Otherwise, bringing back patient for the lateral X-ray, then it's better to discuss whether it's really needed or you should go for the next year. It depends on what you're asking for.
Thank you. So there is one question from the audience. How can we differentiate fibrosis with the consolidation? If you have can answer quickly on that.
We'll come into that in the COVID and the other things. Yeah, we can mention that there.
Okay, that's right. Now again, coming back onto the lateral X-ray, you gave two examples. One is, I think, one of the first cases where the patient had a right lower lobe pneumonia, which was not seen on the PA view. And if the clinician has a good suspicion about something going on with the clinical signs, would that lateral view would help, especially if there is no CT scan available for whatever reason?
Of course, of course. So you can see the images, right? Can you see the images?
Yeah.
Okay. So so this case, actually, if you're suspecting pneumonia, okay, it's just pneumonia, then of course you can repeat a lateral X-ray that will show because heart should be clean here. You'll be see like a band of opacity there that will confirm. So middle lobe pathologies, you can use, if you're not suspecting cancer, you can use a lateral X-ray. And that gives confidence that you're not wrongly treating a pneumonia. Okay. So middle lobe pathology and this thing. So earlier days, there was a practice like when you always do a lateral X-ray so that whatever behind the liver, those areas will be covered, kind of thing, especially for lung cancers and everything. But then because nowadays we are doing low-dose CT for lung cancer screening kind of thing. So, okay, so smokers, we are screening them with CT, okay? So for a symptomatic patient with you in your clinic, should not be hesitating to do a CT if you have any narrow suspicion for a cancer. So you should have a low threshold for CT in those cases. Yeah.
Of course. Now, Dr. Harris, I don't know. I mean, obviously, you had a big selection of beautiful slides, and I don't know whether you already had it. One thing that probably we didn't see was only heart failure, which is a very common situation in an emergency room. Do you have any slides to?
Yes, I think I'll share it towards the end or later part of the discussion.
All right. Okay. That's fine. Now, I think we will close this session. We will go straight to the next session, where now we have seen how to systematically go through an X-ray, and then Dr. Harris beautifully gave some examples and themes with some clinical correlation. So the next session, what we are doing is, now the chest X-ray is only a part of that your management of patient. There will be a clinical history, other lab investigation, X-ray, and then management, then maybe another investigation, then maybe another X-ray or another imaging. So how we see how we have to see this X-ray only at one point in the whole journey of a patient. And now we can see few clinical cases, how this, clinical and radiological is become a one in managing a patient. So now we have a few eminent speakers on, we'll be talking about different aspect of it. And with me, I also have Dr. Rahman, who is a good friend of me. I know him for a long time. He's a interventional radiologist with an interest in vascular imaging. He's at Leicester Hospital. Now he will be helping me with the question and answer session at the end. Now, if I could invite my first speaker, Dr. Rafiq, who is a pediatric consultant, and he will do a self-introduction to start with. Dr. Rafiq.
Thank you very much, Dick. Just going to share my slides first. Are you able to see my slides?
Yes.
Yeah. So my name is Dr. Rafiq. I'm a pediatric consultant in the University Hospital of North Midlands. For about 15 years, I was a consultant in pediatric intensive care. Then now I do diabetes and endocrinology and also general pediatrics. So it's just a smattering of cases that we've seen over the years. And just to put a bit of a contrast between what you see in adults and what you see in pediatrics. And it's just a short 10-minute session on looking at some x-rays. And then in the end, hopefully we'll have a bit of a summation of what the cases that we've seen as well. So I'll talk about common presentations and some pitfalls as well in pediatric radiology. So one of the common ones that we see is when we get one of the juniors having a look at this x-ray, and somebody posted earlier, how do we look at mediastinal widening in pediatrics? And one thing in pediatrics is the age of the child that you need to consider. So if you consider this child is a young child, and we know that the thymus is prominent in somebody at this age, and so mediastinal widening usually is bilateral. In this case, you've got the sharp borders in this case, and this is otherwise called a sail sign, and is common when you have the thymus that is still quite large in young children. And this can occur on both sides. This happens to be on the right side, but the same thing can happen on the left side as well. So that's about the thymus. The next thing is about pneumonias. Pneumonias in children, unlike adults, you don't get nice round shadows of lobar pneumonias. What's common in children is more bronchopneumonia. So it's a confluent shadow that you get. So it's more diffuse. And sometimes you can get that behind the cardiac border as well. And again, you don't get the usual symptoms of bronchial breathing and the sounds that you normally hear with pneumonia in adults. You don't always get to see in children. The complication of pneumonia then obviously is empyema. And we tend not to do CT scans routinely when we find a picture like this. We tend to do ultrasounds. Again, because of the thinness of the chest wall, we are able to get good resolution images on ultrasound. And it's exceedingly rare that we find tumors behind this. Normally, it's either a sympathetic effusion or an empyema. So in children, most of them are well until proven otherwise. So more often than not, what you find is you'll find these pictures. And when you do an ultrasound, you'll find a fluid level, which will then guide you to put a chest drain in one of these. Yeah. Foreign bodies can present in more ways than one. And in this case, if you look, and this is where it gets a bit tricky, because foreign bodies is to differentiate which side the foreign body is on can be quite tricky in patients, in pediatric patients. And especially since you're struggling to even get a history. So sometimes you can have a 3-year-old who mom gives a classic history of was either playing with a toy or was eating peanuts when he suddenly coughed and spluttered, which you can understand for a 3-year-old. But how do you get that story in a 6-month-old who's not mobile, whom mom has not given anything? What you shouldn't forget in those cases that 6-month-old could have a 3-year-old who's then shoved something down his nostril, down the 6-month-old's nostril. So you should always be mindful that there could be other factors in this as well. So if you look in this case, you can see what Harris Bhai described as a whiteout. This whiteout is on the left side because what's happened is the foreign body has gone into the main bronchus here and actually completely occluded the airway. And so you get a collapse of that side. As opposed to in this thing, which can sometimes happen as well. So in this particular situation, what's happening, the foreign body is actually on the right side. But what it is the foreign body goes and lodges in a bronchi and acts like a ball valve. So what it does is, as the patient breathes in, it allows air in, but when the air tries to come out, the foreign body goes and obstructs the bronchus. So what happens is you get continuous enlargement of the right lung. It can produce a pneumothorax at times as well, but you get hyperinflation of the right side. So in the first one, you had it on the left side with a complete obstruction and then resolution of the air in that and producing a collapse. Whereas in this case, what you have is the ball valve effect actually producing a hyperinflation of that particular side of the lung. And of course, you can get complicated features. So if you depend on whether the, sometimes you have Lego toys with holes in between. Some of them are absolutely solid. So it depends on what the foreign body you're talking about as well. The next question we want to look at is bronchiolitis in children. Again, bronchiolitis is a very non-specific one because it, like, for example, in this case, all you have is hyperinflation. And if you look at, there's narrowing of the cardiac shadow because of the hyperinflation of the lung. And you can see this patient's got an NG tube as well, because obviously the patient is struggling to breathe. And this is another one of this of bronchiolitis, but in a different child. And you can see the hyperinflation on both sides. And what is obvious is the prominent bronchovascular markings that you see. And these are typical viral bronchial markings, as opposed to any patchy consolidation. So this diffuse airway shadows are because of bronchial wall thickening. So it's bronchovascular markings that are there with an element of hyperinflation of the lungs. So this is a typical picture of somebody with bronchiolitis. Again, like Dr. Afsar showed earlier, this is a patient with dextrocardia. And one thing I always say is, even when it comes to clinical examination, we do not pass anybody in the exams if you don't examine for cardiac impulse on both sides. Because if you think about it, the one age when you're likely to pick up dextrocardia or problems is when you're younger. Because if by the time they're 50, they would have been to the GP 20 times. And so somebody would have picked up dextrocardia at some point in their life. So you will have it in the history. Whereas in pediatrics, when you see the patient for the first time when they are 3, they might be the first time somebody is examining the cardiovascular system. So you need to make sure you're examining on both sides. And this is a classic example of somebody with dextrocardia. And this, again, is somebody with cardiomegaly. And in this case, you can say that this is probably a right ventricular hypertrophy because of the way the heart is. It's slightly shifted on its axis, and you could almost call it a boot-shaped heart, this is. So this is somebody with right ventricular hypertrophy. Now, what happens is it becomes quite tricky to work out whether this is really cardiomegaly or not. As Afsar said earlier, you need to make sure that the patient's well expanded or they've taken a good inspiratory breath. If not, the heart will look relatively compressed in a pediatric age group. So the way to do that actually is to do what we call a cardiothoracic ratio. So how you measure the cardiothoracic ratio is the heart is not evenly enlarged on both sides. So what you do is you draw a line through the middle there. And once you draw a line through the middle, you take the widest part on the left side and the widest part on the right side. It might not be necessarily in one line. So you need to consider the two areas where it's widest, add them together, and then you take the two costophrenic angles and see whether this is less than 50% of the total thoracic ratio or not. So normally the cardiac ratio should be 50% of the cardiothoracic ratio. So if it's more than that, then you probably have cardiomegaly. Yeah. And my final slide, I haven't put any title on this. So this is a 6-month-old who presented with a sudden episode of 24 hours being unsettled, crying, and struggling to breathe at times. And we did a chest X-ray and couldn't really work out. There was no major cardiac issues there, no major respiratory findings that we've done until somebody then pointed out and said, if you look closely, if you look there, what you can see there are rib fractures. Okay. So this is a healing rib fracture. So what we need to consider is in the pediatric age group, you need to look for those things that are slightly out of the ordinary as well, because they're not good historians. You're practicing veterinary medicine. So basically in a 6-month-old with this type of history, it's important to look closely. And what you can see here is a rib fracture. This is possibly some child who's had their chest squeezed for whatever reason, and this would be treated as a suspected non-accidental injury. So I'm going to stop there for this minute, and Dr. Rahman is going to try and summarize any features, and if any immediate questions there, I'm happy to answer this as well. Thank you very much for giving me the opportunity to present these slides.
Thank you very much, Dr. Rafiq. That was an excellent and precise and concise presentation about what various pathologies you can see in pediatric age group. Just in keeping with our trend from this morning about tying up the clinical and radiological findings, blending them together and correlating them, I just want to highlight a few points that Dr. Rafiq has already said. Number one, from the radiological perspective, we try and do ultrasound more often in children and avoid radiation. We try not to go for a CT scan, unlike adults. And in pediatric age group, children are generally very healthy, and they go on a long time before they become suddenly unwell. So they are very resilient. So therefore, it's important to pick up early clinical signs and not wait longer. Important thing to remember among children is, apart from the unique pathologies that you have in kids, for example, like a pneumonia in a child can be sequestration. It could be a collapse is usually a foreign body, unlike a tumor in an adult, or not to forget the non-accidental injuries. But apart from those, you also have congenital abnormalities and variants to remember among children. The normal variants usually are picked up when in children compared to adults, as well as there are congenital variants, like Dr. Rafiq presented a nice example of dextrocardia. Similarly, you could have coarctation or any other abnormalities that you could come across in a pediatric age group. Hopefully that will sum up our session very quickly before we move on to the next presentation. Are there any questions, Siddiq, that we need to answer at this stage?
I don't think we have any question at this stage. If I could ask one question to Dr. Rafiq. Rafiq, I mean, how often you see the patients pneumonia misdiagnosed as acute pyelonephritis or acute appendicitis? How often is that in your...
Actually, it's almost like I set up this question with you, Siddiq, because just last week, we had a patient who presented with what looked like a pleural effusion on the right side, a right lower lobe pneumonia stroke pleural effusion. And then when you went back into the history of that patient, he had an appendicectomy a year ago. So, and when he had the appendicectomies in children are quite nasty because it's very rare that we get a clean appendix. More often than not, they're ruptured and they have peritonitis because they're more difficult to diagnose. So this chap then had quite a bit of a messy abdomen. And this patient actually had a subphrenic abscess. And what we were seeing above the diaphragm was just a sympathetic pleural effusion. And I've had the reverse as well. I've had patients who have gone in and had an appendicectomy because surgeons don't think chest, do they? If the patient had a chest X-ray, he had actually had a right lower lobe pneumonia. But the appendix, if you remember Bailey and Love, you can have pain in the abdomen from anything from tonsillitis right down to appendicitis. So this patient, all he had was a pneumonia, but because the pain was lower abdomen, they went and did an appendicectomy. And this could easily be misdiagnosed with the pyelonephritis as well. So I think it's keeping an open mind about these things. And like I said, pediatrics is slightly veterinary medicine. So you have to cover the length and breadth of the chest and abdomen before you make that decision. So I've seen both sides in answer to your question. I've seen pneumonia being misdiagnosed as appendicitis, and I've seen intra-abdominal pathology being confused as a pulmonary pathology because they have sympathetic effusions as well. Absolutely.
Thank you, Dr. Rafiq.
And just to add to that, Dr. Rafiq's point, there are a lot of pathologies in children that happen uniformly from throat down to the groin. For example, mesenteric lymphadenitis could be associated with tonsillitis, for example. So you have to keep your eyes wide open and think out of the box a lot of times in pediatrics.
Every year, I get at least one patient from urology department, which they presented as acute pyelonephritis. Go there is chest X-rays initially normal, and then maybe the next year or something they'll refer to, because I was told the pleural diaphragmatic recess is low, so there may be some pleuritis or infection there, which even low in children. So there could be a kind of a normal chest X-ray with all the pain presenting as a kind of an acute abdomen. Now, just to move on, we have the next session is on immunosuppression. It will be done by Dr. Maqsood and Dr. Afsar together. Dr. Afsar, who we are starting first with?
Yeah, that's brilliant. Dr. Siddiq, I was already here as the chair earlier, so people do know me, and we can crack on with the presentation. Dr. Afsar, are you ready with the slides, please? That's excellent. Thanks ever so much. You know, the way we do in hematology is we work together as a team with our beloved radiologists. They come to our help whenever it is special help. Particularly, I'm tremendously pleased to have Dr. Afsar with us today, who runs the hematology MDT. We are going to discuss 3 cases. The first case, Dr. Afsar, if you could kindly take the first case, please. This gentleman actually presented with, he's got myeloma, and he's on chemotherapy with cyclophosphamide, lenalidomide, and high-dose dexamethasone. And when he came to the clinic, he was quite short of breath and just had a dry cough, wasn't coughing out anything. And when I was just, I don't think I'll give more clues at this point. But anyway, we sent him for a chest X-ray because of the shortness of breath to see what exactly does it look like. And this is the chest X-ray. Could you kindly tell us what does it show, please? Well, sorry, we are unable to hear you, Dr. Afsar. I think you're muted.
Afsar, are you mute? Afsar, are you?
Yeah.
Yeah.
Okay.
Yeah, you are unmuted. Yeah.
Yeah, you can see the image, right? Yeah. Okay, so this chest X-ray, basically, just like what I said, straight away when you look, initial itself, you can see there's a lot of haziness around here, okay, central part. You don't see really dark, I can't see really dark air, you can't see. That's the normal air you see. So that's the normal air you see. So you can't see that kind of a picture all around. You can see a lot of haziness. And as you can see here, they're not like pneumonia, like a big opacity, but instead you can see small nodules and small linear kind of things. That, and the whole thing is filled with that. And that's basically perihilar, like central part of the lung. Okay, so that's, it has a pattern, like a same kind of abnormality based on the central part of the most central 2/3 of the lung fields, and there's no separate consolidations you can't see. There's no pleural effusion. As you can see, the hilum, the density of the hilum looks okay. You can't see any widening of the parietal areas, or there's no cardiomegaly. So in this kind of picture, obviously the atypical pneumonias comes as the first differential here. Okay, and among the atypical pneumonias, PCP, pneumocystic carinii, is the top differential you can suggest from the radiology. It cannot be confirmatory on just an X-ray. Even on CT, it cannot be completely confirmatory, but it can be brought as a top differential here. Pulmonary edema, to differentiate this, when you have so much of change, you should see more of a bit more alveolar opacity kind of thing, and there's no cardiomegaly, there's no redistribution of the vessels. So those things we don't consider cardiomegaly here. Any infection, bronchopneumonia, still you can put as a differential. So in this clinical setting, PCP will be the first thing we'll ask to test. And if that's negative, then patient might require further testing and even BAL, like kind of thing, if not responding to treatment. So what happened to this case, Dr. Masood?
Yeah, the patient was getting desaturated on a little bit of exertion because he was immunosuppressed with high-dose dexamethasone. We were thinking of the atypical infections, particularly pneumocystis carinii pneumonia is fairly common in this age group. So what we did was requested our pulmonary colleagues for the bronchoscopy. The patient's saturations were not that bad. They proceeded with the bronchoalveolar lavage, and PCP was confirmed. And we treated this patient with high-dose Septrin and steroids as well, and the patient recovered. We used to see this story quite commonly previously. This is becoming more and more rare, particularly in patients who are being treated with high-dose steroids, because we give them cotrimoxazole prophylaxis. With Septrin prophylaxis, we have been able to bring down the number of PCP cases tremendously. So PCP prophylaxis with Septrin, or if allergic to Septrin, we use the other alternative prophylactic treatments. that is how the PCP cases have come down tremendously. So now we have got the, so the main thing here is the lymphopenia and lymphocytes being very low. So this is the type of infection that this group of patients usually present with. So the next patient, if you could kindly put in the next chest X-ray, thank you. This is a 61-year-old gentleman with anaplastic large cell lymphoma on chemotherapy. He presented with neutropenic fever, and this was the initial chest X-ray that was done as a part of the neutropenic septic screen. Could you kindly tell us what does that show, please?
Okay, so this X-ray, 60-year-old, okay, there's nothing straight away. When you look at X-ray for a few seconds, you can't see anything significant here. And the lymph fields are quite okay. There's nothing in the hilum, nothing increased density there. There's no opacity in the upper lobes. So patient eventually had another ongoing symptoms. Patient had a repeat X-ray later.
Yes, just before that, because this patient had neutropenic fever, we straight away started off with the treatment as part of the neutropenic sepsis protocol. And the patient continued to spike temperature. That is why we repeated the chest X-ray again. And could you kindly go through the full series?
Compared to previous X-ray, you can see that there's not much big changes. I can't see any big pneumonia or anything developing. But if you look closely, you can see some additional lines like interstitial changes are there. Some are coalescing. So there is something happening. Definitely, the chest could be the source of sepsis because you can see things evolving. Yeah.
Dr. Maksud, can we skip your third case and go to the next session? And if you can come back to the third case, if you have time, is that okay?
Yeah, no, that's fine. That's fine. Thank you.
Thank you. Thank you.
So I'll quickly take through the multiple chest X-rays this patient had. So this patient then on the further follow-up chest X-ray, patient was not responding and had more widespread changes like this. And so here again, just like what we discussed in the previous case, all these differentials come. Patient had CT scan. CT scan just showed the same thing, and you can't really prioritize any differential. But definitely lung is abnormal throughout. And patient had a CMV pneumonia, came positive, and that was the only thing positive. The patient was treated for that. Then again, patient initially improved, but then again went back to the square one. And as you can see here now, you can see a bit more, the opacities are a bit more dense and a bit more coarse kind of thing. And at this stage, we have all guns were already fired, there's nothing else more to treat. And so then patient is on rituximab, thought, okay, this could be a drug toxicity because that's of course the diagnosis of exclusion. It was rightly treated as neutropenic sepsis, but then at that point steroids were started and patient showed improvement eventually. So the key thing is, of course, these cases we have to treat as neutropenic sepsis, but then drug toxicity can show the same way, same pattern. Yeah, Maksud, by anything?
That's brilliant. Thanks ever so much. Over to you, Dr. Sindhya.
Okay, thank you, Dr. Maksud and Dr. Afsar. I'm sorry, we had to, I'm sure the third case was even more interesting, but we have to see whether we have a time at the end. Now, could I invite Dr. Arun Dev for a very topical discussion on COVID. He's a consultant at Heart of England's NHS Foundation, Birmingham, and he will give you a short introduction and do his presentation. Dr. Arun?
Hi, hello. Can you hear me?
Yes, yes.
Hi, thank you for having me here. Mine is a short presentation.
Slide to share, yeah?
Yes, I think Afsar is going to do that, yeah.
All right, okay, that's fine, yeah.
Thank you. I've called these images of the time because just going back in time, if you remember 2002, when the SARS-1, when it was called just SARS, came and 8,000 people were infected and 800 died. That's a mortality of 10%. 2012, then MERS came, 1,000 cases, but 40% mortality. And now we have a beast of nature, COVID-19, which has seen 120 million cases worldwide with a toll of 2.7 million deaths, which is actually only 2.2%. What makes it more worrying is the contagiousness compared to the other previous coronavirus problems. So I will start with just a short story and then end soon, only 5 slides. This is a gentleman, a 61-year-old acute medicine consultant physician who was wheeled down to my acute respiratory unit on Christmas Eve of 2019. He had symptoms of COVID for around 10, 12 days, mainly the normal ones. You would say he felt a few sniffly, he was feverish, he had some chills, and he had a bit of cough. On the other hand, I think the video is over there. Can you hear me?
We can see your images, but not the video.
Okay, that's fine. We'll carry on with that.
Yeah, you can.
So, yeah. So he came and he had some constitutional symptoms, but he didn't have any shortness of breath. He appeared to be comfortable. When somebody took the oxygen saturation, it was only 75%. So this is the condition where we say happy hypoxia. Patient is not obviously dyspneic, but at the same time, the oxygen saturation is very, very low. This was an X-ray on presentation. And if you look at it, you can see it's bilateral sort of patchy infiltrates in the mid-zone with some loss of definition of the diaphragm. They are bilateral, they don't have any lobar distribution. But anyway, he was brought down to my unit and it was found that his oxygen demands were increasing, as was his shortness of breath. So within a few hours, he became very unwell. Next slide, please. You can see that now, bilaterally, there are peripheral opacities, which is affecting here, the mid-zone on the right, mainly with the flattening of the diaphragm, and on the left side, which has become more confluent. There are some airspace shadowings as well. So by this time, because he was unwell, we put him onto high flow oxygen at a rate of about 75 liters per minute and 70%, which is as high as you normally would like to go. And initially, he seemed to be getting better, and he was only on treatment with dexamethasone. He was on high flow for about 10 days and was getting better symptomatically, and we thought that we were winning. So, next slide, please. He became more unwell and had to be taken to the ITU to be intubated. So he was on high flow for about 14 days, appeared to be getting better, but then got worse with signs and symptoms and radiology consistent with early ARDS. You can also see some airspace consolidation on the left side, and the left lower lobe is almost completely wiped out now. He stayed on the ventilator for some time, about another 7 days. And then next slide, please. You can see that the next one, thanks. You can see that the infiltrates are now sort of solidified into rounder opacities. There is some evidence of airway dilatation as well, and the endon experience, and the endon look on the right side. And he was getting worse and worse. And I would like to actually show you a CT image as well. This is the next day after intubation, where he actually developed a pneumothorax, as you see on the left side, and he's got the central line there with some surgical emphysema. One of the radiologists asked me whether it was a iatrogenic pneumothorax, but I think it is associated with the COVID pneumothorax and pneumomediastinum. By this time, we were giving up hope, and to be frank, 21 days from his admission, unfortunately, the consultant physician passed away. The last slide I have here is of the CT scan, which was done at that time. And you can see in the coronal sections as well as the axial sections, you can see that there are ground glass opacifications, there are the crazy paving type of opacification, some fibrotic streaks in the upper zone, traction bronchiectasis, good going consolidation, and there is very little normal parenchyma left. So this is just a short drive through of a patient's journey. And some of the things that I'm reminded is that only 20% of patients with COVID symptoms, early disease, have anything on the X-ray, and you cannot even see anything on some of the CT scans, which is quite surprising. But if you take a scan on these patients, asymptomatic patients, after, say, 4 weeks or 6 weeks, sometimes these asymptomatic patients have got airway opacities, which you would be surprised, given that they were not even hypoxic. So it is not a typical, it's an atypical pneumonia with some signs of organization. And the last stages, you have fibrotic streaks, which will result in them being respiratory cripples for the rest of their life. And one message I would say is that mostly we say, as I said before, don't treat the chest X-ray, treat the patient. But in these cases, don't just go by the chest X-ray or what the patient tells you. Go very much with the oxygen demand. It's a very different beast. That was a short presentation, I'm sorry.
Dr. Afsar, are you going to take us through some of the images?
Yeah, okay. So I think people have asked in the chat box, like how to diagnose COVID pneumonia on X-ray. So at the end of thing, you will know that X-ray is useless in diagnosing COVID pneumonia. So here, this was the first X-ray in this patient. And as you can see, there are small opacities like airspace shadowing, and there are some interstitial kind of linear shadows. In an event of COVID pandemic, patient suspected of COVID, okay, this can be taken as an early COVID sign on a chest X-ray, but if not in a COVID situation, it can be any bronchopneumonia, any of those things. Okay, there's nothing specific for COVID in this case, in this X-ray. So that's one of the limitation of chest X-ray. That is only to guide management. This next X-ray, as you can see, more like a lobar or segmental subsegmental consolidations kind of thing. This again, it's just like any other consolidation, any other pneumonia. You can't really differentiate that. This is how the pneumonias look on a chest X-ray. And as it goes down, those pneumonias have cleared, and you can start seeing more of interstitial thickening and more of coarse shadowing. And as you come down, as you can see, these kind of nodules, like organizing pneumonia, like the development of organizing pneumonia pattern is explained in COVID. So this is all mixed up with fibrosis and the active lesions. So one of the questions in the chat box was whether you can differentiate a consolidation and a fibrosis. The answer is no. If you're just seeing a small opacity, and whether that opacity is fibrosis or a consolidation or active lesion, even CT sometimes struggle. But on a large area of fibrosis with the volume loss, everything, a chronic thing you can mention, but what you expect in a COVID situation where you have patches of fibrosis, you can't really tell. Only time will tell, even on the CT scan, follow-up CT, many of the fibrotic areas, what you think of fibrosis can resolve. Some are permanent, which are definitely fibrosed and non-functioning lung. So in this X-ray, I think I'll just show one subtle finding, which is maybe useful. As you can see, the first X-ray here, just look at the diaphragmatic margin here. The way the diaphragm dome goes, like the normal diaphragm, the apex of the diaphragm is in the midline. That's how the normal diaphragm will be in any patient. And as you come down to this X-ray, you can see a bit flattened, the apex has gone laterally. And that is a sign of subpulmonic effusion. When you have fluid under the lung, that can be taken as a subpulmonic effusion. Then this patient had a pneumothorax. As you can see, there is a visceral pleural line. And you must have seen in the previous X-rays, which Dr. Harris showed, those lines were thin. Okay, so that when you get thin line, then of course, definitely it is pneumothorax. But when you get a thick line like this, where you can see, you are not seeing a sharp line, then you have to actually evaluate carefully. The pseudopneumothorax, which is caused by different things externally, like a blanket or a tubes or a skin fold, they can have thick margins like this. Okay. Also, when patient has underlying fibrosis or the underlying lung doesn't behave like a normal lung, they also can have a bit thicker line. So in this patient, underlying lung fibrosis caused this kind of thick line in the pneumothorax. And as you can see here, the bit of additional lucency around the heart. That could be the only sign sometimes in ITU patients you see, where the X-ray is, the air is collected anteriorly. Okay, you may not see a proper line, visceral pleural line, and this may be the only sign to pick a pneumothorax in a portable X-ray sometimes. Yeah.
Okay, thank you, Dr. Afsar, and it's an excellent description of the findings. Now, I do a post, I think there are some questions about what happened to these X-rays or this patient later. I do a post-COVID clinic. What I've seen is just like a normal pneumonia. Most of the patients, those who come back after maybe 6 to 8 weeks of a COVID, the X-rays, going back to normal, just like other pneumonia. But of course, there are patients who have some, residual changes, fibrotic changes. But vast majority of them just like a normal pneumonia, the X-ray would go back to normal over a period of maybe 6 to 8 weeks time.
Yeah, that's a very good message actually, because many people are worried in the early stage when they do a CT scan, and many times the CT scans are reported as fibrosis, and many think that okay, this rest of the patient is going to live with much less lung reserve. So many things clear, only some part remains. Yeah.
Yeah, I mean, obviously, this is, kind of a generalized observation, but patients those who have been to intensive care, and especially those who spend maybe more than 2 or 3 weeks in intensive care, we do see some, residual established, fibrosis, some kind of limitation. But in general, obviously, vast majority of patients, those who get COVID doesn't get into ICU, even though that, is what more people are worried about. Now, I think.
Sorry, I was just going to say one word about the people ask about the long COVID symptoms. And I think recently NICE has come out with the guidelines regarding management of long COVID. I mean, traditionally, we're being told about the symptoms which are lasting for more than 4 weeks after the COVID infection. And that's what they call the post-acute COVID syndrome. It's found that I believe 20% of patients with COVID have symptoms after 5 weeks, continuing symptoms. And the main symptoms are not entirely respiratory, like chronic cough or dyspnea or chest tightness. The main, one of the studies in Lancet that came on last week says that the most important things that they say, the most important symptoms they're saying are cognitive decline or impairment, sort of foggy brain, and fatigue. And very interestingly, post-exertional malaise. Those are the 3 most common ones rather than respiratory. Is that your experience in the post-COVID clinic as well?
Yes, I do. I think, most of the, patient which, apart from the breathlessness, even breathlessness is more of, dysfunctional breathing than, organic symptoms. But of course, as fatigue is one of the a common symptom which linger around for weeks, even sometime months. Yes. Now, shall we move on to the last session, which is Dr. Riaz. Dr. Riaz is going to discuss clinical governance issues related to a chest X-ray. Now, obviously, when we do X-rays or when we treat patients, we will treat them, but also I think important that we have a discussion about how the misdiagnosis or how our action on X-rays and images can lead to other medical, legal, or clinical governance issues. So he's going to discuss a few cases with is it with Dr. Afsar Riaz?
Yeah, Dr. Afsar. So can we get the can you get the first slide, please? Yeah. Again, good morning, good afternoon, good evening. I think it's good afternoon and good evening to most of you. I think you're all tired after such an excellent session. There's been very, very skilled speakers who've been talking, and it's very, very hard act to follow after such an expert, after a series of expert talks. Now, the only reason why we put this in the very end is because I think it's very, very important to recognize that, we all talked about interpreting X-rays and getting the X-rays right and, making sure that everything's okay. But at the end of the day, we got to make sure that if we didn't get it right, what happens? It is a very serious issue. It can be life-changing for people. And indeed, you don't want to be ending up in the courts. So we have this sort of common terminology that we use more commonly in our areas, and especially in the United Kingdom. The people who are from India won't recognize this term. It's called as clinical governance. So the main reason why I brought this up is to know what is quite different from in India compared to the United Kingdom and other places, because this is a process and a framework in which the NHS organizations are accountable for improving the quality of the services and safeguarding high quality of care. Now, this is essentially a means of saying that the patients should be safe and we should be safe as doctors, and the mechanisms to ensure that it actually happens. Next slide, please. Now, if it doesn't happen, next slide, officer. If it doesn't happen, we end up with a medical error. Yes? And sorry, the previous slide. What is a medical error? A medical error includes as limited to the misdiagnosis and mismanagement of an ailment that a patient is afflicted with. Then, as already mentioned, it can result in extreme lifelong preventable injuries in affected patients. The point about preventable injuries is what is very, very important for all of us. We don't want to misdiagnose. We don't want to mismanage. You get the diagnosis wrong, you get the management wrong. So it's very, very important. Next slide, please. And it's quite surprising to know that in the United States, there was a study they did, and 2.5 million patients, or 250,000 patients, sorry, 250,000 patients, 250,000 patients died because of medical error. And that was the third commonest cause of death way back in 2013. You can see how important this is. Yes, next slide, please. So with that in view, we don't want to end up with these sort of headlines, do we? You know, medication leads to inquiry and your whole life is shattered. So we always have to be careful. Next slide, please. And going back to, you know, when we talk about chest X-rays and the various things about chest X-rays, what is the specific reference to chest X-rays? There could be errors related to the actual process, to the exposure. Yes, it could be the positioning of the patient, to the exposure of the patient, and also related to IT problems. Now, demographics, your patient data, patient information, that can always be wrong. You always have to check if this is the right patient, this is the right surname, the site is correct, as you all know. But these things always happen. And very, very important, I think there's an important bit of the story that you tell the patients. You know, your history matters. And most of the time, the radiologists get really annoyed at the question you ask. And the reason is because you don't ask the right questions. It's very, very important that you put the right information in. And as a result, because you don't ask the right questions, it doesn't prompt the radiologist to look at the right answers or give you the right answers. And of course, there is a difference. There was a question asked earlier on about differences in a geriatric population. I'm a geriatrician. There's a lot of difference because anatomy changes over a period of time. You have to take this into consideration. The anatomy with the disease lung, the anatomy without a disease lung, the anatomy with changes over age. And of course, the competency levels. You know, you might be a registrar, you might be a junior doctor, and you might be a senior consultant. You always have to make sure that you're skilled enough to do that job. And also interventions. Interventions do change and make you, you know, do errors. Human factors, as we all know, we get stressed. You know, we have a bad day. You know, we may not be, you know, in the best of ourselves. So these factors are also so important for us to cause errors. Next slide, please. So with that in view, we just want to look at a few error scenarios because I'm conscious of time and I want to make sure that, you know, we want to finish this as soon as possible. So we get errors in interventions, we get errors in missed or wrong diagnosis or sorry, wrong findings. And also we get errors with anatomical variations. Now, a lot of these have already been covered in the previous slides. So I want to quickly go through them before Officer helps me out with some of the X-rays. Now, one of the commonest things that happens with patients is nasogastric tubes. As you can see, now, Officer is going through the nasogastric tube. I don't know if it's very, very clear showing up. So nasogastric tubes is very, very important. We know that we all have to put them down every single specialty at some point or the other with unwell patients. And you can see if they're not being put properly, you can see the first nasogastric tube going onto the left lung. The second one, again, has been resited for the same patient, is going on to the right lung. Can you see that? So it's very important. Then the next slide, please. The next one you can see, it took about 3 attempts. And actually the guidelines say that after 3 attempts, you've got to stop. Yeah. So it's very, very important that you get into you know, get it right. Okay. Now, going on and moving on. Now we can think about that's one of the errors that can happen. If you see, this is a common problem that we often face, and I'll let Officer go through this X-ray with you later on. But you can see that this looks seemingly in the stomach, but it's actually going through the left border of the lung. Yeah, and it's actually not in the stomach. So this is a common error that can happen. If in doubt, you withdraw, take it out, repeat it. That's what you got to do. Yes. Next slide, please. And you can also have situations like this in which there's a problem with the airways. There is a problem with the positioning of the patient. The nasogastric tube is coiling around and around and going up to the skull. Again, next slide, please. So, and when you get it wrong, this is what happens. You get food, you get you know, all the rice and curry and everything onto the lung, and that's chemical pneumonitis and consolidation. So this is not what you want to happen. Yeah. Next slide, please. Now, going about just a few things about you know, nasogastric insertion. What is the National Patient Safety Agency? You know, which tells us what to do in terms of nasogastric insertions. You've got to make sure that it is really required, and you need 2 competent individuals to decide if it's required. It should be fully radiopaque. And you've got to confirm the position of the nasogastric tube. Now, it may be different practice in India, but here you do have to confirm the positioning because of all reasons mentioned. You've got to do the gastric fluid first, the fluid pH first. It should be less than 5.5. The second line, it is chest X-ray, but in most trusts in the country, there could be variations to this, but this is what the national guidelines say. and you got to stop after 3 failed attempts. So this is the first thing about nasogastric tube insertion, very, very important. And just for you to know that about 20 patients died because of faulty nasogastric placements within 2011 to 2015. That's when the NPSA started this alert. So you got to be very, very careful. It is important. And there were about 200 cases reported. These are reported cases. There are lots of cases which are not reported. Okay. Moving on to the next one. We'll do officer's talk after pneumothorax. Next slide, please.
You want me to just finish off the?
Yeah, if you just want to talk about it, yeah. Okay.
So as he said, the right position. The one thing you have to make sure that at least 10 centimeter of the NG tube, the distal NG tube, should be below diaphragm. So that you will have all the side holes below the diaphragm. Otherwise, you will have food going into the esophagus and can aspirate. And this X-ray was, Dr. Riaz was doubting. So if you see that in the first attempt, it has not gone really down in the stomach, and you have a doubt whether is it in the lung or is it in the esophagus, whether we should withdraw and push or you can directly push. So in those cases, you can always identify the left main bronchus here. Is it on the left side, right? So if it is going into the bronchus, definitely it goes along with that. And the bronchial division start just before the hilum. So if it is going down here and then it dips down or goes straight, then it has to be in the lung. If it is crossing the air column of the bronchi, then it has to be in the esophagus. Okay, so this case it is crossing medially the air column, so that you can push it directly. You don't have to withdraw. Yeah.
Thank you very much, Dr. Afsar. You can see why we need radiologists to help us out, because these are sort of things which always, as clinicians, as physicians, we have a doubt. And most of the time in UK, the junior doctors who actually look at these confirmed placements, that's why it's so important. Next slide, please.
Yeah, that's the...
Yeah, this is the next slide. So you can see this is another problem with an intervention. As you can see, there are multiple tubes. This is often a problem with X-rays. You have multiple tubes. You don't know which tube is going where, and you can see a central line that's going down there. And if you look closely, next slide, please. This is a post-insertion pneumothorax. As you can see, that little pneumothorax there, that's actually going there. So again, pneumothorax, as I was just reading up the complication rate of central lines, is about 5 to 25%, and it's actually 1 to 2% that you can have a pneumothorax after a central line placement. Yeah, so you can see Dr. Absar is actually showing that pneumothorax line over there. So it's very, very important that actually, we have to be very, very careful. These are also, but these things do happen. That's the most important thing. You got to report it. You got to just make sure you be wary of it. That's what the most important message it is. You do need to do just check X-rays on these patients. However confident you are, you do blind procedures, but that doesn't make you a hero. You have to do X-rays and make sure you're safe. Okay, let's move on. Next slide. Now, this one is, this is another patient. This is quite an interesting one. Now, this is a patient with I think this was covered before. So if you closely look at this patient's story is the patient had a new, a pacemaker inserted, and after 2 days, the patient came with chest pain. Yes. So immediately, it was a very astute doctor who saw the patient and decided that there is a little line there, as you can see. This is quite an elderly patient. There was a little line there, and they thought it was a pneumothorax. Immediately, it was decided that the patient should have either an aspiration or a drain. The patient said, I'm pretty okay. I don't think that I'm not breathless. I don't have any problems. I don't think there's air. My lung is not burst. So the patient refused. And the next day at the posting, there was still a doubt. What is going on with this patient? And as you can imagine, can you go to the next slide? That was actually a skin fold, and that's actually confirmed on the CT scan. You can see that skin fold over there. Yeah. So you can see how things can go wrong. Yeah. And skin fold is not an uncommon thing that you find in older people. Yeah. Next slide, please. Again, this is another interesting case in which there was a case of misdiagnosis. Now, this was a lady, an elderly lady who presented with a history of a fall. She fell on her side, and then when she came in, she was quite confused, and she fell, and she had a lot of pain. Now, this was 12 hours into her admission. She was called for a peri-arrest call. Yes, her blood pressure dropped, her hemoglobin dropped, and this is, as you can see on the right, there was hemothorax there. Now, what's happened with this patient is this patient actually ended up started off with a fall, had massive pain on the left side of her chest. We could hardly, you could hardly touch it, and if we actually exposed her, there was a lot of bruises there, but this was overlooked. And if you look closely at the first X-ray, there was a rib fracture there. You can see, as Dr. Afsar is pointing out, there's a rib fracture there. She ended up having a regular warfarin, and she was also given aspirin, which is a regular treatment. And she ended up having a pneumothorax 12 hours later. and she arrested, and she died, unfortunately. So this was again a case of very avoidable harm. It is very difficult, but this is the main message here is the clinical story. The patient was screaming in pain. Nobody bothered to have an examination. Yes. So, Dr. Afsar, I don't know if you want to add on anything over here.
No, I think we touched upon the pneumothorax earlier. Yeah. So I think we already discussed it. So it's another example here. You can see there's like a thick line. So it's like a thick band. So if your pleural line is here, you can see it's like a thin line. Okay. If you're seeing a thin line and that line is within the lung parenchyma, within the lung fields, and you can't see any lung markings beyond. The lung markings, you have to be very careful. That's a classical teaching that you won't see any lung markings beyond that. But that is described that you will see in a proper PHS radiograph. But if patient is in a slightly semi-erect or supine view, you can have lung behind or anterior, and some lung markings may be seen. Okay, so you should not go hard fast on that unless it's a PA X-ray. So this lung markings, thin line, it is pneumothorax. If it is thick line, definitely you should suspect a pseudopneumothorax. And another thing, the key thing is no one want to miss. The people rush for aspiration is because they don't want to miss a tension pneumothorax, which can kill the patient. So for just looking at an X-ray, the key point for tension pneumothorax is you should see a flattening of the diaphragm. Diaphragm gets flattened or inverted. And you can have mediastinal shift. If patients treat the patient, not the X-ray. So if you, as this patient rightly directed the clinician not to aspirate. So if your patient is comfortable, sit tight, take expert opinion before jumping for aspiration. Yeah.
Okay. Yes, is this your last case, or do you have?
Yeah. It's. I think we're going to the next one. So just be careful about that. So this is the last one. We just got to say another. This is about abdominal changes and X-rays when you actually look at. Like me being a clinician, chest X-ray, abdominal X-ray is all, is all valuable to me. So you can see this is an erect X-ray which is done, and it's very, very clear. There's air under the diaphragm there, and and there's the X-ray on the right. You can actually see. It does look like a bowel loop there, doesn't it? For my eye, and looking on especially on the left side below the diaphragm there, it looks like a bowel loop to me. So I wouldn't have said unless you look at the patient clinically. So that's actually a perforation as well. So if you go on to the next slide, please. But then when you have a close look at this one, you can see similarly on the left there's air under the diaphragm, and the same patient having a bit of the X-ray done after some time, you can see there's a proper bowel loop there, which is what most of you know as a Chilaiditi syndrome. So this is actually benign Chilaiditi sign. This is actually a very benign condition. Now, if this patient did present with pain, it's called as a Chilaiditi syndrome. So you can see how difficult it can be, to distinguish between the two if you're not very astute. I don't know if Afsar wants to come in here quickly.
I think it's all like whether it's incidental or not, and especially elderly patients, you have to be careful. They may not show signs of peritonism initially. So if there is any suspicion, definitely you have to do CT. And in all these cases, the previous X-ray will help confirm that patient has colonic interposition. In this X-ray particularly, you can see there is a separate air lucency line here as a crescent there. That's outside the bowel. So definitely there's pneumoperitoneum there. Yeah.
Let's move on. And I think just to tell you the last slide, I mean, there's, if you can see over here, this patient was treated as chest infection pneumonia on 2 occasions. The patient came in 2 times, treated as pneumonia. Second time, got antibiotics, developed Clostridium difficile diarrhea, C. diff diarrhea, which was actually, you caused harm. But this patient actually has got a pericardial fat. That's what it is, isn't it? Afsar, you want to fill in?
Yeah, it's just something which is lucent, and it's like fat will be lucent like this, like the subcutaneous fat you see here, and you can see vessels, everything structure behind that, and it won't merge with the heart. You can still see a cardiac margin. If that's a pneumonia sitting there, usually they will have the same density as the heart, and that silhouette the heart margin. So you can see the nice heart margin separately, and look at the previous X-rays; it will be there if you got a patient as a previous X-ray. Yeah. In rare cases, sometimes you may have to do a CT to confirm if it's not very typical, but most of the cases it can be cleared on an X-ray.
Yeah. Okay. Excellent. Let's move on. The last question, I think, Afsar, I'll let you take this because it was a question about rib fractures, isn't it? Afsar, do you want to discuss that rib fracture there?
Like sometimes the upper first costochondral junction especially can have weird appearance. Then people can suspect mass, and this and can alert the patient that there could be a lesion there, and the CT will show that it is not, there's just a calcified osteochondral junction. So that's one area where people get confused. Always take an opinion before going for the next investigation or telling the patient.
Excellent, thank you. So again, the changes in anatomy is there. Look, there was a question asked about geriatric population, why they're different and X-rays are different. Is very, very different. They have a lot of pathology in the lung previously. They have a change in body habitus. There'll be kyphosis, fibrosis, osteoporosis, osteopenia. Osteopenic may look like lung lesions. Lytic lesions. So there'll be a lot of changes in the lung anatomy as well as the anatomy of the musculoskeletal system. So you got to look for all this. That's what's important. Next slide, please. This is the last summary slide. Take-home message: errors do happen, but learn from it. So don't try to hide it. Don't try to hide it under the carpet because you keep repeating it. If in doubt, always repeat the X-ray. Always seek help. Don't be overconfident. Don't be the macho person that I made a diagnosis of, first time around. It will cost a life, as we saw in some of these cases. And also, interpret X-rays. Look at all the other structures around the X-rays. Be very vigilant. I think that's all I got to say. I think we will move on and ask Dr. Abdurrahman to summarize.
Thank you very much, Dr. Riaz and Dr. Afsar. That was wonderful. I think we had a wonderful 2 hours of all presentations from various speakers, and it was quite interesting to hear the clinical and radiological or imaging perspective, and that's what we wanted to do, keep it all interactive as much as possible, and I think we have achieved it to a good extent. Now, what I want to convey some key messages here is that we can't reach chest X-ray or teach chest X-ray just in 2 hours. There are courses that run for 3 days just for chest X-ray interpretation, and some dedicated ones if you want to attend them. But in these 2 hours, what we have tried to convey is some key messages to what you should look for in chest X-ray and what you should do about them. And looking at chest X-rays is an art in itself. You have to have your own system as to how you look at them. Afsar Bhai told us about how he looks at the chest X-ray. Somebody else might want a different system where you have a A, B, C, D, E system. You start from airway, go to the lungs, and go outside to the diaphragm, chest wall, and external organs. Now, there are many ways of looking at it, but what is important is have your system and look at everything. And also try and compare, when you see an abnormality within the lungs, try and see where it is coming from, whether it's from the airway or the bronchi, or whether they're from the alveoli, or whether they're from the interstitium. That's the main key message. They look slightly differently. Although there is some overlap between them, they look a little bit different. And try and see if you can identify those key points from what Dr. Afsar and Dr. Harris have described today. And in X-rays, it's all about shades of density, different shades of white and gray, different shades of gray really, and as to whether you can find out as to whether it's a soft tissue or a bony abnormalities, whatever it is. So that's important to remember. The most important message that we got from today's discussion is that to treat the patient, not the images. And that's why radiologists always say in their when there is any doubt, they always say, please correlate clinically, talk to the patient, take that history. And that's been said many times today, I think. And if in doubt, ask for help, ask a radiologist in the department, or consider further imaging. If you're in doubt, always consider follow-up imaging. And that would be the safest thing for the patient and for you as well. Okay, thank you very much for listening, everyone. Dr. Siddiq, I'll hand over to you.
Thank you, Rahman, for a sleek and quick summary of the events today. And I hope all you learned something from these presentations. We can go forever, as Rahman said. The chest X-ray is a very important part of any clinician's life, and it is so complex and sometimes so difficult to interpret correctly. Now, so I hope everybody learned something from these sessions. Now, I just must say that we have some technical issues at the beginning, which, sorry for that inconvenience. Some of you could not join with us on time. And of course, thanks to Rubaz and Siad and our technical team, they corrected it very quickly and managed to get everybody on board. Now, please do leave your formal feedback. Of course, you can leave some feedback on the chat box. But please do remember to leave your formal feedback, which will be mailed to you. And it will also help you to get the notification on our next sessions straight into your mailbox, so that you will not miss any sessions you may have. So just before I conclude, let me thank all the speakers, those who have spent a lot of time to prepare and to give you a kind of very quick summary of chest X-ray and its clinical implications. And also thank you for all the audience which they have been attending from, I was told, maybe more than 10 countries around the world. And sorry, we did took a bit of extra time, more than what expected. So once again, thank you all, and goodbye. Dr. Riaz, you have to say anything?
Sorry. Yeah. I just like to add, if anybody wants, if you want to give us a flavor of what you want for future sessions from the radiology perspective, it'd be better. We do all sorts of, not only radiology, we do everything. If you can just put that in the chat box for now, it'll be helpful for us to know what you would be interested in, and we'll keep all of you posted. Again, a big thanks to all of you, and a big thanks especially to our IT team. You know, there's a lot of work. It's they get bored with listening to CTs and X-rays, standing for about 2.5 hours, you know, supporting us. So a big thanks to all of you and the Thai speakers and to MHM. Thank you. I think with that, we'll conclude this session formally. If anybody of you wants to hang around for informal discussions, we are around for about 15 minutes. So formally, our meeting is over, but informally, if anybody wants to.
Somebody was asking for, particularly for heart failure, pulmonary edema on the chat box. We didn't do time to cover that. I can quickly go through a few X-rays if people want to stay back to hear about that.
Yeah. So we'll just give it 1 minute or 2 minutes or so for people to leave while you get your X-rays ready. If you load up your X-rays.
Yeah. Can see. You can see the X-ray. Yeah. Okay. So I'll just quickly go through the focused part in the diagnosis of pulmonary edema, heart failure on a acute heart failure, pulmonary edema on a chest X-ray.
Sorry, Afsar, 1 minute. There was a question about, is there a formal feedback form? Just to repeat, the formal feedback forms it's already been linked over here, but it also be sent to your emails so that you can actually do a formal feedback back. Okay, sorry. Sorry.
Yeah, well, okay. So basically the pulmonary edema sets in 3 stages. Okay, so first stage is the redistribution of the vessels, redistribution. And the second stage develops an interstitial edema. Then it goes to the alveolar edema. Okay, so it's got 3 stages. So we can identify these stages on a chest X-ray. So the first stage, the redistribution, is where you start seeing the dilated vessels in the upper lobe. Okay, so you can see that cephalization, it's called. You won't see normally big vessels going up. When you start seeing that, that is a sign of redistribution in a patient where you are clinically suspecting pulmonary edema. And the vascular pedicle, which we described earlier, like for dissection and everything, so that gets widened and that gets response to the fluid status. And as you can see here, there is redistribution of the vessels, and that is getting cleared with the treatment. Okay, so in very early pulmonary edema, this could be the only sign. Patient can have a cardiomegaly for the underlying heart condition, and then early cephalization could be the only sign you see with very early pulmonary edema. Next stage is where the interstitial edema sets in. Okay, it's like it happens in a course, in a continuous course. So here you can see some cephalization. Along with that, you can start seeing a lot of interstitial thickening. Okay, you can see crisscross a lot of lines. The hilum become less defined. Okay, and you can see small fluid coming up. So this is the stage where you got the interstitial pulmonary edema. Okay, and as it goes further, this is like a proper, like a well-established interstitial pulmonary edema, where the perihilar, you can see a lot of shadows. There is cuffing around the bronchi, and these things what you see here, these are all interstitial thickening. That's called curly B lines. They are perpendicular lines you see in the lung bases, like as you can see here on both sides. That is a sign of interstitial edema. Okay, it's not highly, it is not like, it can happen in other cases where you can have interstitial edema, interstitial thickening, and sometimes even lymphangitis, carcinomatosis, you can get that. But in a patient presenting with like kind of pulmonary edema picture, this help you to tell that the patient has got interstitial pulmonary edema. Okay, so from this stage where you are seeing the hyla is enlarged, perihilar opacities are starting to develop, this is a stage of interstitial pulmonary edema. And yeah, I think you got a zoomed view of the Calibi lines. And the next is a classical described bat wing appearance, where those interstitial edema, where then fluids start getting into the alveoli and you get airspace opacifications. And as they spread from the center, as you can see, the classically described bat wing pulmonary edema. This is the alveolar stage of the pulmonary edema. Okay, and that you can see different phase and the way the patient, because it's all the fluid filling in the alveoli, they are dependent thing. So depending on which side the patient is lying, so it can be varying on either side. And this is one kind of X-ray you see in like patients not able to take a deep breath. You have fluid and you will have perihilar shadows. There's one kind of appearance you get in pulmonary edema. Yeah. And these are like mixture of interstitial and alveolar opacities. And at this point, if you're seeing a pulmonary edema at this stage, it will be very difficult to differentiate whether it's is bronchopneumonia or pulmonary edema, but clinically you have to go by what it could be. The main thing is the pulmonary edema is just fluid coming and coming out. Okay, so the patient symptoms and the X-ray correlates well. Okay, when the patient is symptomatic, X-ray will show signs. Symptoms so will show the opacities, will show all the changes. And when the patient improves, X-ray also follows that. X-ray shows good clearance. So on a first day, on a first sitting, first X-ray, sometimes if you're getting a patient in this mixed pattern, you may be difficult to confirm it's pulmonary edema, but on a second X-ray, you should be able to confirm it, because if you're treating the pulmonary edema in the right way, the fluid is coming out, then X-ray should respond. If X-ray is not responding, then you are not dealing with pulmonary edema. And also you can have overlaps, because a bad lung infection can precipitate pulmonary edema in this case, in this patient. So you can have overlap as well. So if something is clearing along with the patient's symptoms, then that is pulmonary edema. That is fluid what is gone into the lungs. Yeah. That's an X-ray of ARDS, where you can see that there's not much of like perihilar thing. It's widespread, and the main thing in ARDS is that there is a delay and in the onset and delay in the resolution of the opacities. Okay, so initially the patient oxygenation can be bad. Still, you may not see much in the chest X-ray, but changes are already there at the interstitial level, at the opacity level, lung level, and eventually you will start seeing lung changes. And even this patient can show good improvement, but the lung changes take time to resolve. Okay, that doesn't follow the patient's symptoms in an ARDS. Yeah, thank you.
Afsar, can I ask you a question? One of the as a clinician, which is who looks after about 30 patients in a day or beds or whatever it is, there is this question often asked that we repeat the X-rays, and we would like to have a resolution of symptoms or ARDS and pulmonary edema or pneumonia, whatever it is. But quite often the radiologists are not very keen on repeating the X-rays, and they say, no, why are you doing it now? You wait for 6 weeks or wait for 10 weeks or whatever it is. Can you shed some light onto this on a practical level?
Yeah, no, pulmonary edema, I don't think usually radiologists never get involved in that in an acute setting. But then pulmonary edema, definitely you have to repeat X-rays. You may have to repeat many X-rays in a day if you have that diagnostic confusion. What you're saying is, if you are treating a pneumonia, if you diagnose, okay, this is pneumonia, and you are not bringing any differentials of pulmonary edema, ARDS, or other differentials, and if it's a straightforward lobar pneumonia or a small communicated pneumonia, you're treating with antibiotics. If clinically the patient, if what I always tell that if patient has an expected clinical course with the treatment, then you wait at least 6 weeks to see the resolution. Okay, but if the patient course is not going well, not like as you expected, then of course I'm always happy to accept, and you can repeat an X-ray. But because the thing is that is to pick whether is there any worsening or is there any alternative pathology coming up? That is the reason. And that repeat X-ray is not to look for resolution. So if you're looking for resolution, see whether the treatment is responding, then it's better to repeat an X-ray after 6 weeks. On a single X-ray, it should resolve. Yeah. So within a hospital, before discharging, if you're clinically responding, just discharge. If not responding, if you want to confirm that it's not worsening before discharge, you can repeat an X-ray. It depends on what is asking.
The other common problem that we often have is we see a lesion on the X-ray. It looks like consolidation. We don't know if there's an underlying mass or a mass around that. So that's another one. You say wait for 6 weeks, repeat the X-ray, see if it's not responding, gets a CT done. I mean, I'm sure most of the oncologists will say you can't wait for 6 weeks because there's a mass. You're losing valuable time.
Yeah.
So again, what is your take on that?
Yeah, no. If you're suspecting a mass, I don't think. See, the thing is, the X-ray is a lot of imperfections in X-ray. X-ray is a very primitive test, but still holds good because of the lot of good things it has. So nowadays nobody want to wait and do things. A lot of legal issues and everything going on because technology is used like anything in every aspect of our life. So we should not be shying away using it in real correct context in our health issues. So if there is a suspicion of mass, definitely you should go for CT. You should confirm it. You don't want to delay it. Definitely, there should not be there should be a low threshold for that. But everything is pneumonia. Everything goes well, and in those cases only. And in our practice, we rarely refuse such cases for a CT. Suppose sometimes in like very young patient, 25-year-old, and suddenly you want to know any chance can it be a mass? Definitely, yeah. In those cases, sometimes we might think if it's definitely classically looking like a pneumonia, we can wait and see. But otherwise, because I've seen like even very senior radiologists getting it completely wrong on X-rays. Okay, so I always say like if a hilum looking abnormal, even if someone tell you that okay, if two people says that okay this is fine, someone says no, there could be a doubt, then I'll go with the doubt. Okay, because that is the specificity of findings on a chest X-ray, especially those areas. So you don't want to miss a cancer there. So you should go ahead with the CT in those cases. So I have low threshold to accept CT scans in those clinical settings.
Yeah, excellent. So that goes back to my last presentation, in which you say you'd rather be safe than be sorry. Yeah, because we're living in a world in which we have so much access to diagnostics compared to many of us did many years ago.
Body, I can take that risk. But if on somebody else's body, if I got a finding there in the imaging, whether it's any scan or anything, if I got things to say specificity, statistically, with evidence practice, it is proven that this is highly specific for the benign entity, then I can hold good on that. I can say, okay, this is a proven benign finding. You don't have to do that. But that's not the case when you're dealing with a chest X-ray. Many of the CTs we refuse. I do refuse a lot of follow-up CT scans. Where CT scans, the specificity goes higher, where you can say that, oh no, this is benign, I'm sure, you don't need a follow-up CT in this. Okay, but that's not the case with X-ray. The specificity is not that high in X-ray in most of the cases.
Yeah. Excellent, thank you very much. That was a great discussion. One of the respiratory physicians, I don't know if Dr. Harris is still here or Dr. Siddiq can answer this. As a clinician, the other problem I quite often face is an effusion on one side. Yes, and then we want to do a CT. Do we need to drain the effusion to dryness, before we actually linger upon doing some scans or CT scan, further imaging, not chest X-rays, but CT scans. Can you, just for the benefit of the generalists and the junior doctors, can you just give us an insight into that, Dr. Afsar, Dr. Harris, or Dr. Siddiq, or any of the respiratory physicians?
Harris, you want to take that?
And speak.
Yes, yeah, that's a very, very good question, Dr. Riaz. If somebody's got symptomatic effusion, moderate to large effusion, I would get it drained because that will help the patient's symptoms. It will help the patient to lie down and to have any further investigations, including a CT scan, because there is no harm in draining. And again, draining to dryness, we use this term often. It depends on the underlying cause. Say, for example, if it is symptomatic effusion for a non-infective, non-malignant effusion, if somebody's had a drain in, I think I would rather drain it to whatever comes out and get the patient for further tests. But whereas if it is infective, again, it is best to get the effusion, because obviously you'd be looking at putting a chest drain depending on what's coming out initially. Like I mentioned earlier, it's a spectrum from a simple parapneumonic effusion to complicated effusion to the far end of the spectrum, which is empyema, i.e. pus. If it is purulent effusion coming out, definitely a drain with a view to basically leave the drain in until the inflammatory markers are settling down. But whereas if it is malignant, then if it is just a small to moderate effusion, we may not need to, but we may not need to drain to dryness or even to drain. And we could go for a CT scan, because I think draining the effusion will help open up the lung and look at lung parenchymal abnormalities. Again, even if we have drain to dryness, we can still go ahead and do thoracoscopy. One of the reasons some of us may not suggest draining to dryness completely is there may not be enough space for us to go in to do thoracoscopy or pleural biopsy.
Okay, excellent. Thank you very much. I think there was, I think Dr. Maqsood has made a suggestion about, is it explaining how to read an X-ray methodically? Can you take us through the processes? So I think this is a question to Dr. Abdurrahman. Dr. Abdurrahman, are you around? By the way, if any of the people who are hanging around, any of the participants hanging around, if you want to ask any questions, just raise your hand and we'll unmute you. Is Dr. Abdurrahman still around?
Riyaz, sorry.
Yeah.
We had a question on YouTube, on the YouTube
stream.
Sorry.
Yeah. So we take some YouTube questions.
Yeah, sorry.
Yeah, get on. Can you give us a question?
It says, for how much time post-COVID fibrosis goes? And I think referring to the healing, I'm not very sure. I'm not best placed to say that, but it says,
so I think Dr.
For how much time post-COVID?
Yeah. So Dr. Anudev will answer the question, but I'll let Dr. Anudev answer this again. Dr. Anudev, how long the post-COVID fibrosis lasts? Yeah.
So the fibrosis is actually, in my opinion, quite over-reported in international journals, for example. From following up a lot of patients, we only find a much smaller number. Once the fibroblastic activity has taken place, so initially you've got like pneumocytes, which are misshapen and dysmorphic, and slowly get replaced by fibroblasts. Once the fibroblastic activity has set in, it's irreversible, just like IPF. But the number is actually quite low compared to what I've seen. If you actually take CTs in, say, 3 months or 4 months, those patients who had what looked like fibrotic streaks actually have resolved. I'm sure that Dr. Polakkal will probably have seen the same in a lot of patients as well.
Yeah, I agree with Arun. There's a lot of kind of hype about the post-COVID symptoms and the long fibrotic changes. Even in my experience, as I explained earlier, most of the patients, those who have had a COVID pneumonia, even a kind of severe bilateral involvement, within a kind of 6 to 8 weeks, that's improves. And actually, their non-specific symptoms, stays longer than the actual X-ray, because I do patient those who X-rays back to normal, but they're giving this kind of, as they have explained, the brain clogging and fatigue and lack of energy, and of course sometimes hyperventilation or dysfunctional breathing. So yeah, I do agree. It's just kind of overhyped, this post-COVID X-ray or lung involvement. But of course, there are a group of patients, they do have changes. But in my experience, again, they are the patients, those who already had some kind of a chronic respiratory disease. Either they had a bit of a bronchiectasis or maybe a chronic bronchitis and emphysema. Those patients, yes, when they do have a COVID, when they recover, they can end up with a bit more of symptoms and complications.
One other thing I probably
just for the benefit of the audience, we said the long COVID symptoms respiratory wise is quite less and the pathology is less, but what are the expected long COVID lung problems that you have commonly come across apart from fibrosis that all talked about?
Not a lot. I think symptoms like cough can continue well after they get out of those people who are hospitalized. The cough I've seen when you talk to them even off the phone, the symptom of cough can persist, and the perception of dyspnea. So at the end of the day, dyspnea is not, well, we used to be taught that anyway, that it's an uncomfortable awareness of your own breathing. So it's not what the others perceive, it's what they perceive as well. I haven't seen a lot of problems in these patients from a lung parenchymal view. The only thing that we probably are not looking into is whether these patients have developed a type of pulmonary hypertension, because there is a good evidence, postmortem evidence, that most of these patients have microthrombosis. And we really don't know how it all pans out in the longer term. But to answer your question, respiratory symptoms, cough and dyspnea are there, but pathology-wise, it's very rare to find anything on follow-up, in my opinion.
Yeah, thank you. Just to let people know that Dr. Arundev runs one of the biggest high flow oxygen units in the country. It's quite busy, so he's got a lot of experience with COVID. And Dr. Siddiq, do you want to add something on to that? Or
most of the patients also come back for the clinic. The most common symptom from the respiratory wise, it is the cough, which just like we do the same thing in other pneumonias as well, like post-infective, post-inflammatory kind of reactionary cough. That is one thing. And this also, again, more common among people, those who already have airway obstruction or asthma or a COPD or some other kind of primary lung diseases. That's the first symptom. And second symptom is, again, as Arun mentioned, the dyspnea, where this is not, it is a dysfunctional breathing, kind of air hunger, typically described as air hunger, or dysfunctional breathing, or sometimes hyperventilation, rather than organic dyspnea, or because of any kind of a low lung reserve. And this is the second one. Third one is, of course, the fatigue, which can sometimes outlast the chest changes, cough, and other symptoms. Again, we are not seeing many other weird and wonderful presentation. Yes, we have seen a patient also had a bit of these are people those who are a long stay in the ICU, where there's some kind of cardiac involvement, bit of myopathy, and sometimes even pericardial involvement. This all kind of the far and few, very hardly just one here and there. But the common ones is cough, air hunger, and fatigue and other related. But of course, sleep is an issue, and other issues. Obviously, with the lockdown, we also do a lot of patients also have their COVID and lockdown together affecting their sleep cycle.
Excellent, thank you. Thank you. I think, can I just ask the radiologist here? I don't know if Dr. Rahman is still here. I don't think we got much chance to cover the aorta on an X-ray. I know we talked about unfolding of the aorta, but any other aortic aneurysm and thoracic aneurysms and things like that. Is there anything you want to tell us about it? What we need to know?
Dr. Riaz, I think you also missed because of that Zoom technical issue. We covered in the first part. I think you're planning to send them the images or something, right?
Yeah, okay, so fine. Is there anything you want to add on that area? Yeah.
Normal aorta, aneurysm, everything was covered in the first part.
Okay. So I must have missed that, sorry. If anybody wants to ask any questions, I think this, I don't know if Dr. Akias is still here. Or Dr. Or probably I'll ask Dr. Harris, just to say, if Dr. Maksud's, I think Dr. Afaq is here, I think, is it radiologist Dr. Afaq?
But he may not have an access to, images.
No, it's just for us to, oh yeah, you might not have access to images, that's true. So can I ask Dr. Harris? Dr. Harris, can you just, there's a question about if you're teaching a junior how to methodically look at an X-ray from a clinician's perspective, just in 2 or 3 minutes. You can just quickly tell us, what sort of things what they need to know. That's what Dr. Maksud's question was. Is Dr. Harris still here? I don't know if he got that question. I'm sure Dr. Afsar covered most of that, but I think it's just probably
Dr. Afsar already covered, and he gave his kind of tips.
Yeah.
I think Maksud wants to check that with
Dr. Maksud want to give another radiologist approach, how the review areas are looked like.
Is there anybody else? I think Dr. Afaq, I don't know if he wants to add anything on, or Dr. Akias wants to add anything on. We are happy to unmute Dr. Akias.
I think Afaq is unmute now.
Yeah, okay. Dr. Afaq.
Everybody. I've been listening with an excellent talk, very well educated, very well directed. I think
can we see your, can you show your video so we can see? Are you in a position to do that? No,
I'm not in a
otherwise
position. Okay.
Go on.
Okay. I think most of the topics have been covered, and there have been excellent presentation and everything have been covered. The only thing I say is people miss things which they have not made as a review areas. The most important bit is when you keep missing things on X-rays, you need to have a review areas. If you look at your own review areas are basically your weakness, where you tend to miss most of the things. And anybody who's reporting or who's looking at the chest X-ray, they have to make sure they know their weaknesses, and they keep looking at this every time. And they have to have a structured tick boxes on each X-ray they look in, and make sure they have in their review areas. That's where they tend to pick up more things. That's the most important. Everybody looks at the lungs, everybody looks at the heart, everything, but they have to look at the weak areas, that is called review areas. That's what I want to add to that one.
Excellent. I think, thank you very much, Dr.
If Maksud is still there, I'll give you my 3 tips as a clinician. Number 1, when I see an X-ray, if I see something obvious, obviously something obvious is that is where our eyes goes first. I'll park it there. I don't go to the details immediately. If I see something on the corner of my something abnormal, pneumonia, whatever it is, I park it there. I do the rest of the survey first. That's one thing I always try to do. Because that's always the problem is when we see something, we hook on to that and then we will forget everything else. So I just park it there and then go back everything and then come back and look at the details of what it is and what it could be. That one. The second one is for the rib, I always kind of tilt the image. I put it horizontally and look at it, because sometimes our viewpoint, if there is any kind of fracture or any discontinuity, if you kind of tilt it, sometimes it become more obvious. I don't know whether probably Apsara don't have to do this kind of technique, because they can pick it even with the normal view, but this is something what I do. The third one is for the hilum. It is always issues and always confusion. What I do is I will draw a straight line from the top of the right hilum straight across to the other side, and if the left hilum is above that line, and that is what we normally expected, but if there is any discrepancy where the hilum at the same level or the opposite level, then I think there is something wrong. Either it could be a mass or it could be some fibrotic or whatever it is. If the left hilum is not exactly above the top, if you draw a line, if not above the tip top of the right hilum, there is something abnormal. I don't know whether Afsar might
any comments?
Kind of simple tips for people like me, not the experts, but
excellent tips. Actually, that was a key thing I was telling you. You have to personalize for yourself, kind of, because this is something which we look daily. Hilum, definitely we noted that in the first session, the hilar position. Left hilum should never be below right hilum, because the pulmonary artery is the main thing you see as a hilum on an X-ray. That goes above the bronchus. So definitely that's a key point you have to look always, yeah. And the hilum look at the density of the hilum. Sometimes hilum can be a bit prominent, okay, but then the density difference is the key thing, okay. So a prominent hilum can be due to rotation or anything. You can look at the previous, it's okay. But then if there's an increase in density, then definitely there's something abnormal there. You have to go for the next step. You can't play around. But and hilum is one area people can go wrong. I've seen many confident radiologists saying that, oh no, that hilum is okay, but I don't buy that all the time, because it can go really wrong there. Yeah.
That is another thing. Like when if you want to have another a CT scan, and the best way to request that CTs, even though you want to look something else, maybe interstitial changes or subtle changes, the best way to query abnormal hilum. No radiologist will kind of question our query.
Can I come in?
Yeah, of course. If it's a normal hilum, it's a purely, definitely normal looking hilum, we can confidently say that this hilum is normal. Only thing is that hilum is slightly looking prominent, and whether deciding that is normal or not? That is the question. If it's a normal sized hilum, normal density, normal position, and you're doing CT only for that appearance, which you think, then expert might say, okay, you don't have to do that CT for that. But if it's
I think Afaq wants to come in here. Afaq.
Okay. One of the very significant point raised by Dr. Siddiq Padakal is if you see abnormality, park it and then go back and look other places. That's a very excellent point, because we as radiologists, as specialists, we tend to do this. We are caught sometimes looking at what we call it as satisfaction of search. What happens is we look at abnormality, we just focused on that abnormality and leave and forget rest of the things. So I agree with Siddiq Padakal. If you see an abnormality, forget about that abnormality, look everywhere else, and then come back to the abnormality where you have looked. That way, you probably won't miss many things.
Okay, thank you. Afaq, I think one thing I learned is, say there's an abnormal hilum to get a CT done, so that's what I
That's important. That's most important.
Yeah, I know. I was just joking. So anyway, I mean, as a geriatrician and looking at a lot of X-rays, one of the things I got to say is, because the amount of pathology and the amount of problems that you can see in an older person is massive. You're normally focusing on single lesions, like you saw the COVID X-rays, the multiple pathology that's been seen there. So when I think about X-rays, I think about there are 5 organs involved in an X-ray. When you look at an X-ray, there's a chest, there's a heart, there's probably the abdomen, there's probably the thyroid in the neck, there's a mediastinum, then you have the musculoskeletal system. Yeah, you may even have the skin to argue the case. But the important thing is maybe part of the brain as well. But the point is, when I look at an X-ray, and like I said, I get more interested in the extrapulmonary aspects of an X-ray. The only thing is, because it gives you a lot of information. The very fact that we spend about 2.5 hours, 3 hours discussing a chest X-ray just shows, and most of the things we had to whiz through. So the amount of fractures that I see, the amount of clavicular fractures that I see, the amount of head of humerus fractures that get missed, because you're not asking the radiologist the right question. So that's something to be bearing in mind. When you look at the thyroid is maybe a bit enlarged there. There's a subtle mediastinums there, which most of us have been discussed. But we see a lot of that, and one of the difficulties when being a geriatrician is seeing the anatomical changes that happens in an elderly patient. There's so much of musculoskeletal changes that happens. It's always very, very difficult to interpret some of these findings. And then the ethical question gets asked to me is, do you want to do really CT scan on an 85-year-old who's very frail? Now, that does become a problem. So, it just goes to show the difficulties that an X-ray can bring upon. Just to highlight that point, in terms of looking at an X-ray on the review areas. Does anybody else have any questions? If anybody wants to raise a hand, otherwise we can wind up, unless Dr. Maqsood and anybody else wants to say and add anything more. Dr. Akyaz, you're here, respiratory consultant. Akyaz, is there anything you want to add?
No, it was an excellent session from Haris. Has lots of slides after mashallah, very well done. Nothing else to add. I think it's everything been covered. I'm like my when I'm not that particularly looking at X-ray, but like it's been said before, clinical relation and something that's not matching. Not to jump into intervention is asymptomatic with a small pneumothorax. At the same time, something not matching, just try to think about it and things like that. Excellent, thank you.
Let me ask a non-medic over here, one of our IT guys, what did they feel about the session? Rubaz, Rauf, you guys, or Siad, you want to give a comment? What did you feel? I mean, did we teach you medicine, or you're going to run away? Rubaz, Siad, or Rauf, any comments?
Yes, I wasn't actually monitoring this. I was actually monitoring the chat session on YouTube and Zoom, and I can see from the feedback, I can see that it has been excellent. All the excellent feedbacks and all that. So I couldn't closely monitor because I have been on between Zoom and the YouTube, but I'm definitely going to watch this online if I have the consent from all the speakers to watch it after the session. But I can see that it has been excellent from the feedback I can see here.
But please, that the chest X-ray is not as simple as it is, just like not just a film.
Yeah, so just to let you know that Rauf is the person who's been tirelessly working behind the scenes, doing everything. He rarely takes credit for it, but he's made this helped this event to be successful. He's helped us with the YouTube when we had the problem. I don't know if Rubas or Siad wants to add anything. Siad?
Yeah, missing is his reflection on his head.
Siad. So just to introduce Siad is a other IT expert, but he's our data expert. So we are trying to do a session for doctors about how to look at Excel sheets and how to do that, how to use graphs on Excel sheets, all the sort of high funda stuff. The amazing guys these guys do, it's just amazing because they helped us. So hopefully we're looking to do a session for our doctors for us. Over to you, Siad. What did you feel?
Thank you. It's hard for me to say anything about that. You're in a different world. Only thing I've learned is when you're taking X-ray, you need to look from the back and the other side as well. Someone mentioned in between. That's something good.
Yeah. Thank you, Siad. So again, thanks for helping us. These guys have been here with us for 3 hours. So Dr. Maqsood is still here. Dr. Maqsood, do you want to give your concluding statements? And I think if nobody has any questions, we can end the show. I think Rubas is here. Rubas, you want to say something?
No, it was an excellent session, Dr. Riaz and team. And definitely there are a lot of takeaways for a non-medic like me. And I'm just going to revise some of the X-ray jargons, which you all have kindly, put onto us. But thank you.
Are you planning to change your child's career from engineering to medicine? Any chance? Just a joke.
That's for the child to decide, isn't it?
Yeah.
Right, Maqsood, but you want to come in and give your final finishing touches, the golden touch.
I think Dr. Maqsood is not available.
Oh, is he not? Okay, I thought he was here.
He left actually. Yeah, he messaged.
Yeah, Afsar, you want to say something?
No. I said like Dr. Maqsood.
Oh, you were just saying, okay, fine. Okay, so I think it's time to wind up. Anybody has got any questions? I mean, if you have any questions, last 1 or 2 questions, please raise your hands. Feel free. We can unmute you if you want to ask any questions.
Yeah, any of these who are in the Excel career groups and those things, you can continue raise these questions. Any doubts in those groups? We can.
Yeah, Dr. Afsar is in that group, isn't it?
Rubas, you are saving the chat as a PDF, aren't you? I mean,
sorry?
The chat, the whole chat.
Yeah.
You're saving the PDF, isn't it? Have you saved the chat as a PDF so that we can look at the questions if there's anything else?
Definitely.
Yeah. Okay.
Yeah.
So shall we wind up then? I think Dr. Siddiq, just do his final word and then we can wind up.
I think we already wound up so many times, so probably we will hardly anybody left there. It only just less than 10 people.
Well, actually, we still have so many people. I think 27. I think they were enjoying the discussion anyway. Okay, so Rubas, if you saved, can I leave them? Can I leave the meeting?
Yeah, I'm going to stop the recording now, and hopefully.
Is it Dr. Junior Harris joining us now?
Rubas, I'm going to stop the streaming as well, yeah? On YouTube.
Okay, Rauf bhai.
Right.
I'll
Are we
stop
good to
the
go?
recording.
All right, cool.
Okay.
Hello?
Harris. Okay, bye-bye. Thank you. Have a nice time in Dubai. Are you coming back?
He has to go straight into a hotel for 10 days. Is that right, Harris?